15 minutes late. Couple of housekeeping announcements. Please, those who have not joined the WhatsApp group, please join it right now. The QR code is being displayed intermittently. Also, there is for the washrooms, there is one washroom just behind you, and it's a small washroom. There's a bank of washrooms near the new seminar room, which is just 5 minutes or 2 minutes walking. The way you came in, just next to it, there's a new seminar room. So they're just connected. So anybody can guide you there. So there are two important things for you. And I think I'll invite Dr. Ramesh to start the workshop.
A very good morning to everybody. I think I am seeing few more delegates to come in. So this is a 2-day workshop, as you all know, and then yesterday we had the first batch who did this workshop, and it was like hands-on cadaver. And because of the number of delegates which were more, so we divided into 2 days. The topics will be the same. The faculty, because everybody is busy, so we cannot call them on all 2 days. So we had a different faculty yesterday, but the training wise it is the same, because professor we have our guest faculty here, Professor Dureja. He is an ex professor AIMS, and he's been the pioneer of pain in AIMS as well as in Delhi, and then he is a well renowned pain specialist who's been teaching not only the anesthesia people but neurosurgeons as well, which is a very rare thing, because we all know that it is an important aspect for us also. And he will be guiding through the procedures which I have shared the program in the group, so you might have all gone through. So topics will be the same. And for the other faculty is our own alumni, Dr. Ashish Tandon from Jabalpur. He is ex AIMS alumni. I mean, he is AIMS alumni, and then he has been practicing pain and minimally invasive spine surgery at Jabalpur. So he is another driving force for all neurosurgeons to take up pain. So I welcome Professor Dureja and Dr. Ashish Tandon for the deliberations today. So the other thing is that we'll be having the lectures first. There will be as per the program, and after the lectures are over, we'll be having the cadaver workshop, which the experts will demonstrate on how to do the techniques. Once that is done, we will have divided you all into 2 groups. One group will go down to the cadaver lab, and the other group stays here in the first floor. So the cadaver lab people will do the names have been already put up on the group. So please ensure that you don't mix up, because that will be a problem for you, because the too many people will actually, you will get to learn less because the time is less and you have to do more. So the cadaver proceedings will be going down below for before lunch. This is, and the people who are in the upstairs, we have some 4 stations. In the 4 stations, we have different how to do the ultrasound and how to puncture, and then all the techniques of ultrasonography. There is a mannequin also, which you can do ultrasound on that, and then do the needling, basically for epidural and things. And there is a spinal cord stimulation model. You can just go and then have a look how it looks like, and then so once that is done, we'll break for lunch. After that, we'll have a swapping, that the group from first floor will go down, the cadaver group will come up. So after that, we'll have quiz questions, and then we'll end it. I hope that you all get to learn today and go back and then practice. And this workshop we hope to conduct every year. So with this, I will now like to call Professor Dureja for his first talk on basics of fluoroanatomy and medications used for blocks. So it is very important topic, because that is how we begin with, and then we go further. Sir, please.
Thank you, Dr. Ramesh. And it's indeed a pleasure and honor to be here. In fact, last year we did a live workshop, and I'm surprised that we are moving down to cadaveric workshop, but that's important, because Live workshop we do from operation theater, and you just see the position of the needle and of course other things, but you don't have a feel of that. And cadaveric workshops are one which generally give you a feel. Although as a pain physician, I love to do patients live and show. But then if it's a small group, I can show it better. But if it's a larger group, it is better that you also have a feel of putting in needles. And this is how we started long time. And not only in India, but I've done in a number of countries, like including Pakistan. I've done a cadaveric workshop where a lot of pain physicians were there or anesthesiologists. The world is getting smaller and smaller. I mean, when I joined as a MBBS student or a postgraduate, I never thought that neurosurgeons and anesthesiologists would be meeting together to share common knowledge. But yeah, things are moving fast and better for the patients. And our ultimate aim is to improve the quality of life of a patient who is in pain and give him a better pain relief. And we should all get together. I mean, like if I still remember that my boss of anesthesia, Professor H.L. Cole, suddenly came to me that he's having a severe radiating pain, and there is a foot drop. So I immediately rang up Dr. Neurosurgery Chief in AIMS, and I said, sir, he has a foot drop. He's 80 years old, but he needs your attention rather than mine. And he immediately said, okay, send him to me. But he decided that since he's 80 years old and there's a lot of degeneration, he said, यार मेरे को सर्जरी करने में कोई इंटरेस्ट नहीं है, तू कर ले. So I told him, sir, although it's not an indication for a neural block, but I still will try. And to my surprise, and you will also be surprised, that within a month the EHL came to 4/5 and foot drop disappeared. And he's still walking 2 kilometers, 3 kilometers every day. So just one block, and I had to repeat it after 3 months. He's totally pain free and all for the last 1 year. So it's like the coordination which both of us had. He said no. I mean, I wanted an opinion because foot drop for me is a surgical emergency. But he thought other way, that maybe at this age there will be more harm than good, and he didn't do it. So in order to sort of do these procedures, we do under guidance, and the guidance, of course, through the ages has been fluoroscopy, but ultrasound guidance has come also recently come in a big way, and ultrasound is not replacing, I would say, but adding on to the localization of various structures, because less radiation, but don't worry, 42 years I've been facing radiation, I'm standing in front of you, so nothing's going to happen. And we do a lot of cases every day, 8 to 10 procedures every day under fluoroscopy. So, but you have to be careful, obviously. I'm not going into that aspect of radiation safety, because that is important. So a thyroid shield is essential, a lead apron is essential, and also cover the lower part. The knees also have to be protected from whenever you're doing. In Australia, when I went there, I saw they put a very important lead sheet, not lead, sort of a lead barrier, and then they do the cases. So they are very cautious. But yes, you have to be cautious. They also use the goggles and they use everything, but caution is very important. You are all young, so a thyroid shield, a lead apron going right below the knee, and eye goggles, if you can probably use it, is important. Sometimes even gloves, which protect you from radiation, are important. And essentially, you will have to be doing. So you will have to be doing patients under fluoroscopy. Sometimes in the learning curve, you may have to use it for a pretty longer period. Also, you have to give longer bursts of radiation. So protection is very, very important. So that's why when you're doing under fluoroscopy, studying the fluoroanatomy is very important for anyone who is planning to do these interventions. And fluoroscopy is one which is a very important tool for visualizing the intricate structure of the spine in a real time and aiding in accurate diagnosis and precise treatment. So basically, what you're doing is that this is a 3D structure, and under fluoroscopy you're making it a 2D structure. So it's not advantageous for you. This is a 3-dimensional structure which is being made into 2D. So you have to understand the fluoroanatomy very well, because you are now compressing it to 2D, and very complex images come when you do, like this is the 3-dimensional structure, and this is what you get on a fluoroscope. So we have a marker, yeah. So you have to understand absolutely the the structures which you can see, and there is a lot of overlapping of the structures. So the transverse process, so the pedicle may overlap, and that's how you get that interesting thing which we call it as a Scotty dog. So three-dimensional structure being made into a two-dimensional structures. And if you see the structures which are more radio opaque, this one, there are more and more structures behind it. So if it is radiolucent, there is a single structure like the lamina. You can see the foramen. You can see, but if it is more radio opaque, there are more complex structures which are behind this. Obviously, we utilize for the spine, we use three anteroposterior, as you see on a fluoroscope, the lateral to see some images, and oblique. And whenever you're putting in a needle, you have to confirm at least, because now it's a three-dimensional to two-dimensional, so you have to confirm in two positions. So if I'm putting my needle in oblique, I have to confirm it in lateral also, so that I'm at the targeted place and at the end point. So two views have to be taken together to confirm whether we are at the right place. Now, importance of each of these views is very important. The patient lies supine and the X-ray beam passes through the anterior aspect of the body, as you can see. So, very important that you align the spinous process as well. So, whenever I tell my radiographer, I tell him that please align, it should be in the midline, the spinous processes should be in the midline. So, these are the spinous processes. And then the end plate flattening. So, whichever, supposing I am doing a procedure at L4 and L5, I have to remove the parallax of the inferior end plate of L4 and superior end plate of the L5. So, flattening of so remove the parallax either by doing a caudal or a cranial movement of the fluoroscope, so that these two are at one particular level. So, this is the spinous process, this is the lamina, the pedicle, the transverse process, and this is the facet joint. So, this is the AP view, and very important that when you are seeing the patient in AP view, do align the spinous process well, flatten the end plates, and sometimes there may be scoliosis or kyphosis, and therein you again have to move the C-arm so that you get a better view. Now, lateral view basically provides a side-on perspective, very important. So, you have to ensure again that the end plates, the parallax is not there, and the foramen outlining is very important. So, in lateral view, the vertebra should be looking like a rectangular portion with no overlapping, no doubling of the structure. So, it's like a rectangular thing which you get, there is no distortion, and more important thing is the foramen, which you should be able to see it clearly, because the end point of the needle when you're doing a transforaminal block will be in the foramen. So, when you put the C-arm in lateral position, you should be able to see the position of the needle in the foramen. So, again, foramen outlining is very important, and this helps us in guiding the needle and knowing the end point of the needle. So, lateral view. Oblique view again, so this is just to show you the various structures which you see. These are the pedicles which you see these are the disc spaces, the pedicle, and then the facet joint. You can very beautifully see the facet joints, and even sometimes on an X-ray also, if you do a oblique X-ray, you can see these facet arthropathies very well. You don't need an MRI to check these. The spinous processes and the pars interarticularis, and you can see beautiful. If there is a fracture of pars interarticularis, you can see that. These are the inferior articular processes, and this is what the information which you get in a lateral view. And these are very important information, very important structures if you are planning to do any intervention on the spine. Now, the oblique view became very famous because of this, the Scotty dog. I stayed in Scotland. I didn't see this Scottish dog, but it is very famous with the radiologists and with pain physicians and neurosurgeons. So, very important that you have to align these facet joints in the lateral view, and so that this facet joint becomes translucent. And of course, you can all make out the forelegs, hind legs, the tail, and the two ears. The two ears are found by the inferior articular process and the superior articular process. The nose of the facet, the Scotty dog, is found by the pedicle. A small bit of the transverse process. These are the lamina and other structures which makes this Scotty dog. But essentially, the key structure which you visualize in a Scotty dog is the facet joint and the eye of the facet joint, which represents the medial branch of the nerve which supplies the facet joint. Because if it's a facet arthropathy, you may have to do a radio frequency ablation of the facet joint, and identifying this structure is very important. So this is the Scottish dog, if you haven't seen, and of course it resembles, almost resembles the appearance what you see on an X-ray. And I was in fact in Dundee, where a lot of these dogs are supposed to be there, but probably I was too busy to see these Scotty dogs. So you have to basically turn the C arm to a 15 degrees oblique position, and you will see lots of such diagrams in your books and other places where the Scotty dog appearance is mentioned. Again, to just to highlight the various structures, the three-dimensional structures becoming two-dimensional, and this is how the spinous process looks, and this is how the pedicle look, and the lamina looks, and which sort of in a Scotty dog, again to highlight this, the eye represents the pedicle. This is the superior articular process. This is the process of the opposite side. The body of the Scotty dog is made by the lamina, hind legs by the inferior articular process of the other side, for the inferior articular process of the fore, and the neck is made by the pars interarticularis. Just to tell you that various structures which form the Scotty dog. Again, same thing which I am highlighting. And now, very important that see, this was the three-dimensional structure made into two-dimensional structure, but this is the transverse process, and this is the foramen through which the nerve comes out, and you can see it over here. And this small branch is the one which goes into the facet joint. So it comes from the dorsal root and then enters at this place. So this is the place where we target for the medial branch. So if I have to do a diagnostic, I'll put my needle here, which corresponds to the eye of the Scotty dog, and I give about 0.2 ml of local anesthetic, very less local anesthetic, because otherwise it will diffuse to the root and there will be blocking of the root, which will again relieve pain. So diagnostic block is just 0.2 ml of 0.5% bupivacaine to confirm whether the patient has a facetogenic pain or not more than that. And if you want to enter into the foramen, then this is the place. Again, there are like safe triangles. There are concepts like safe areas which can be utilized for. Oh my God, what happened? Yeah. So we have concepts of putting the needle at the safe area, because this is again a very important thing, because once you put a needle, we don't have the blunt needles which we use for transforaminal epidural injection. We use the common spinal needle which is sharp tipped, and once you are entering into the foramen, you may inadvertently or you may deliberately sometimes hit the nerve, and if you hit it very hard, you may cause injury to the nerve, and patient complains of neuritis and sometimes very severe neuropathic pain after hitting the nerve. So you've got to be very careful. With experience, you'll come to know that I am approaching that particular area. So the best thing is that you hit the pedicle first. Sorry, next. So best thing is that you hit the pedicle first for the beginners, and then just below the pedicle is the safe area, the Camden triangle. The next slide. The Camden triangle. So this is the safe triangle. This is the pedicle just below the area above the nerve. So it's like a supraneural approach of doing a transforaminal block, and this is the safe area. So you will have a rough guide also. Hit the pedicle, withdraw the needle, and just go inferior to the pedicle, and just about 5 to 7 mm beyond the pedicle, you will get the foramen. So you don't have to go very deep and hit the dorsal root ganglion, which can be disastrous sometimes, most of the time rather. So this would be a better thing. But since I mean, like, the criticism for this particular approach is that it may not bathe the nerve entirely. The drug passes into the epidural space in the superior aspect. So then we have the infraneural approach, which is preferred, and you go below the neural foramen, but you have to be very careful, because the interdiscal, I mean, sometimes the needle goes into the disc also. Anyway, you do a discography and come out, but that is not a disastrous thing. But again, if you want to have a good spread around the nerve, the best approach would be an infraneural. But initially, as a beginner, I think start with this hitting the pedicle and going below the pedicle. That would be the best approach, because there you don't injure the nerve and you get a good spread. So this is the nerve which is coming out, and this is how we go for this foramen. So these are some of the structures which I just wanted to highlight, that this is the transverse process, this is the superior facet, and this is the pars interarticularis. This is when you're doing a transforaminal block. This is the safe triangle, and then the spinous process. This is how these are outlined, and once you start doing the procedure, you'll be able to identify the anatomy very well. Although you are all surgeons, you know, you open up and see, but still, floral anatomy is totally different than what you actually see when you are operating such patients. So, very important that counting the vertebra, very important, because these patients may be having sacralization, lumbarization. So, see the MRI, correlate with the MRI, and then count either from above or below. I mean, the best thing is we count from T12 onwards. So, see the T12, you have the rib, and then L1, L2, L3, L4, not from below upward, because that may be fallacious if there is a lumbarization. And always place a marker at the intervertebral space, and then correlate with your MRI finding where you have the disc bulge, and then go accordingly. Bottom to top, and position of the needle, as I mentioned in the initial phase, you have to always do it in two positions. So if I am putting in the AP view, I have to turn my C arm to lateral to see whether it is inside the foramen or not. And dye confirmation is very important, because I mean, although you may have hit the nerve or anything, unless you put in a dye and see the spread of the dye right into the epidural space and bathing the entire nerve, because our target area is the interface between the disc and the dorsal root ganglion. So that's the place which is getting pressed with the prolapsed intervertebral disc. If you're not able to instill the drug at that particular place, I think all the effort is wasted. So my target area is not the epidurals. So that's why when we started in 90s, we were giving interlaminar epidurals, caudal epidural, but the drug was not reaching at that area. That's why these transforaminal or root sleeve blocks came in. When we know that when we should instill the drug, right? So you give lesser drug, you just give 10 to 20 milligram of the drug, and it should bathe that area which is at the interface of the disc. That's the inflamed area. So you have to be reaching at that particular area, and mandatory that you must put the dye. Similarly, I mean, a word about the cervical spine, because we do a lot of procedures in the cervical spine, not transforaminal at the moment, but more of cervical epidural. So it is important that the anatomy of the cervical spine should be very well. This is the articular pillar, which is important for medial branch block. This is the facet joint, and the foramen and other structures, which I'm sure you will all be aware. And for a interlaminar, we do it in the AP view. The interspinous area is the place from where we go. I'll show you the slides in my next lecture. And again, to how to align and to visualize various structures, the facet joints and the lamina and the intervertebral foramen. Very important that you should be able to outline the structures on the fluoroscopy. Now, regarding the drugs, because part of the lecture was also drugs, and very important, local anesthetics, we preferably use drugs which are preservative free. Rather, we just use drugs only preservative free. No preservative containing drugs should go into the spine because of their probable neurotoxicity. Although you give less volume, but still you should try to avoid, because we are not sure the preservatives which are there in the local anesthetic can be neurotoxic. So we have 0.25% bupivacaine, which is available preservative free. We have the Xylocard, which is used for arrhythmias, which is preservative free. So these two agents are the preferred agents. We have even ropivacaine, if you are very much interested, which is preservative free. So all the other drugs like the 2% xylocaine we can use for skin infiltration, but not near the spine. Contrast agents, like I'll just again my 40-year story, I must tell you that we didn't have Omnipic when we started 30 years ago. We were using drugs which was used by urologists, urographin, which is a non-ionic ionic dye rather, and there are known things, but actually there was no Omnipic available, at least for the pain physicians and for neurosurgeons. It was available for the radiologists to do myelography and to do coronary angiography, not frequently available. So we were managing with urographin, and one day, I mean, like I had one patient who had an inadvertent intrathecal injection of urographin. Why am I highlighting that? Please never use a ionic dye. It can be disastrous, and inadvertently it went to CSF. Patient has spasms. Patient had respiratory arrest. Put on ventilator. Came out next day. That is a different story, because I was in AIMS, so I could manage the complication. But in a private sector, you have to be careful. So never ever use a ionic dye. Only a non-ionic dye, which is Omnipaque, Iohexol, iodinated, but it is totally non-ionic, and it is like we use it for coronary angiography, we use it for myelography, nothing happens. Still, again, again highlighting that this particular agent can also cause anaphylaxis, but to a lesser extent, and it is very, very rare. And again, my 40 years of experience, I had one patient. She said that I'm allergic to Omnipaque, and I said, I was a little young that time. I said, nothing happens, that I have given in thousands and thousands of patients. And she said, no, be careful, I develop hypertension. मैंने ठीक है कोई नहीं, do it, I'll give a test dose. And with just point 4 or 0.5 ml, she had a fall in blood pressure. It was in private sector, but I could manage because she had already warned me, so I had kept my mifentine and other things ready. But this can happen. So always, whenever you're using a dye, please ask the patient whether you have any allergic reaction. Although, I mean, these are the dyes which generally are used by the cardiologist, and they don't do it, take a test dose. But rarely the allergic reaction to Omnipaque is also there. But I had no choice because either I don't do anything, don't put in a dye, or just put in a C. But definitely don't put in a dye rather than putting this. And then of course we use normal saline for uh, flushing the drug into this. So this is the drug which I said we have Omnipaque 300 which we use. You may dilute it or you may not dilute it. We don't dilute it, but you can dilute it if you are a little more cautious. And so if you are in doubt, just ask the cardiologist what is the dye which you use, and he will tell you that use this because that would be the safest. Now, a lot of controversy about the steroids. Obviously, ultimately, whatever effort you're doing is to put in steroids to give relief to the patient. And there's a lot of debate going on whether you should use this steroid or other steroid. And also, the techniques have changed because of the steroids which caused some damage. But obviously, be careful. But most of the reports are anecdotal. We don't have any clear-cut study causing, telling that these are dangerous. So we have particulate steroids, we have non-particulate steroids. But obviously everybody knows that the particulate steroids are the one which have better anti-inflammatory effect, which have longer duration of effect. But it has been seen, not in human beings, in animals, that these particles can get together and make granuloma formation. They can irritate the nerve structure and cause some damage. But this is only in animal studies, not in human beings. And if given intra-arterial or accidentally intravascular, they can cause thrombosis of the spinal artery or embolism and cause paraplegia. And these are all anecdotal reports which have been reported in the literature, but no big study or no study which mentioned even more than 2 patients of this. So non-particular steroids, as I said, they don't have particles, they are clear solutions, like you would have seen dexamethasone, metabethasone, short-lived anti-inflammatory effect. So if you're doing a procedure, I would prefer to give a longer relief than a shorter relief. So we have dexamethasone sodium and betamethasone sodium phosphates, which are fully soluble, but as I mentioned, very short duration of effect. But if you want to play safe, you can use this. But if you are bold and you want to give a longer duration and be careful while injecting, aspirate every time, you can easily use methylprednisolone, triamcinolone, and betamethasone acetate. This is not available in our country, but these two are very much available, and they have a pretty long duration of effect and can be used. These are like particulate suspensions. The particle size in methylprednisolone is the maximum, and betamethasone has the smallest. So your choice. But as I mentioned, there are reports anecdotal about intravascular injection, and that is the reason why the transforaminal or selective nerve root block in the cervical region was abandoned, because they said that because the spinal artery is very close, the vertebral artery and the branch which goes along with the nerve is very close to the nerve. You have a possibility of accidental injection. So better to avoid selective nerve root block. Give a epidural instead, where you get an equal amount of spread. So this was about the fluoroanatomy. If you have any questions, we can take that, and the drugs which are used. Anything if you want to ask, can I? I use methylprednisolone. I've been using it for last 40 years. I use triamcinolone also, but these are the two drugs which I use. For particularly joints and all, I use triamcinolone, but for spine, I use methylprednisolone.
So is there any place where you use ropivacaine?
Basically, the local anesthetic, as I mentioned, we generally tend to avoid putting a lot of local anesthetic in the spine because they cause motor loss, and you have it fast turnover. You want the patient to go out after 1 hour, 2 hours, so they have motor loss, so we don't use it. unless you really want a good relief in pain, and you can use ropivacaine, which is a shorter acting local anesthetic.
So some people I heard they add soda bicarb with
Hmm.
the
With
uh,
the with the
local
steroid.
anesthetic because they say it's very acidic. So your
Yeah.
take on this?
I mean, that has been sort of a long age-old thing which has been into the literature. But I mean, I would tend to avoid most of
Okay.
the drugs. Spine is like a temple, so I would tend to avoid most of the drugs and more of the drugs. Rather give drugs which I have more experience, which are safe. Omnipaque. No, no. It has to be like in the spine only. Intradermal test dose of ioxol, I don't know. I have not heard about it. No, no, like, no, no, not intravenous also you can give, but then you have to be careful, no? But as I said that it is very, very rare. It's like 0.0005%. So normally we don't give test dose. Like if, even for local anesthetic, everybody says give test dose, but nobody gives because the incidence is very rare. And you should obviously, this is very important that whenever you are doing these procedures, all the emergency drugs and the anesthesia machine and perhaps an anesthetist should be in attendance because vasovagal attacks, anaphylaxis to local anesthetic, anaphylaxis to drugs can happen. And you being on the side where you are doing the surgery, you may be in a sort of a position that you may not be able to resuscitate the patient. So that is a must. All emergency drugs. We have had to use sometimes mefentine and noradrenaline and adrenaline because of the because of various complications. But the rate is less, but you have to be prepared. You have to have an ambu bag, an ACR machine, oxygen, everything there. These procedures cannot be done in a OPD setting. You have to be doing in an operation theater setting, all aseptic precautions with all emergency drugs available and some help in the area where you are working.
Thank you, sir. You can
I
start
can
with the
start.
next talk.
Okay. You want to call someone else? No problem. अच्छा, दो के बाद थोड़ा मुझे रेस्ट ठीक selected. हाँ ये selected लिखा होगा ना ये. So the next topic is now, although we have discussed few things about this, but it is cervical selective nerve. Somebody else is talking on thoracic and lumbar. No?
Yeah,
Lumbar
I'll
you're
be
talking.
talking.
So as I mentioned in my previous lecture also that because of there is an association called the International Spine Injection Society. So about 10 or 15 years ago, they put it in on the net, some recommendations. They very clearly mentioned that selective nerve root sleeve block in the cervical region should be abandoned. Now, this is the access to this is there for every general person. So once it is mentioned, you got to be careful. I mean, although it's the easiest procedure in the cervical spine, you as neurosurgeon would prefer to do this rather than a epidural because that involves a little bit of technique of loss of resistance and other things which anesthesiologist is more used to. But I should warn it, or it's like a statutory warning that the selective nerve root blocks in the cervical region are not the one which should be preferred. The facet blocks and medial branch blocks are very important, and you may have a lot of patients. I'll discuss a little bit about this facet arthropathy with this thing. Cervical radiculopathy is very important, very common cause of a neck and leg, hand pain, and they come to us in good numbers. And this is the type of MRI picture. And obviously, as neurosurgeon, also you would like to wait for 4 to 6 weeks conservative, but sometimes they are in so much severe pain that they say no, no. And obviously, surgery of the lower spine maybe they would prefer, but surgery of the upper spine they are very scared, very scared. You all are knowing all these facts. So these are the patients who would come to you, and on examination, if there is no neurological deficit and it is just the pain, these are the candidates for either a selective nerve root block or a epidural. Although it is said theoretically that you should wait for 4 to 6 weeks of conservative treatment, but look at the plight of the patient. He is not able to sleep at night. He is just sitting the whole night because as soon as he lies down, the pain increases. So sometimes you have to take the decision early on. Like I had a patient only 1 week back where only 4 days of pain, and she said, "I'm the whole night I'm moving from one place to the other. Please do something. So that's sometimes you have to sort of obviate, go deviate from this and go for epidurals before 4 to 6 weeks of conservative treatment. So it can provide significant benefits in patients who have cervical radiculopathy. As I mentioned, a transforaminal approach would be a better approach because you are instilling the drug like in the lumbar area at the dorsal root ganglion at the area of interface of the disc and the nerve root. But because of the higher complication rate, we are preferring interlaminar. Again, as I mentioned, there is no clear-cut study. There are only reports of paraplegia, but there are like 4, 5, 10 maybe in the literature. And based on that, everybody recommended that should not be used. But once it comes on the internet and you used it and something happens, then of course you are liable for these things. So that's the reason why less and less. Although, I mean, like it was so simple, I'll show you how simple it is. Cervical epidural space is smallest 1 to 2 millimeter diameter. So that's one problem which you have in cervical at the level of C5, and then uh, increases on flexing the spine. So your position while giving epidural is in a flexed position so that you have a more than 2 or 3 millimeter of space, because there's very little area to put in your drug in the epidural space. So that you have to be very careful. And the vertebral arteries and cervical neuroforamen being very close, that you may inadvertently inject into this. Very important to understand the anatomy, and obviously I am not going to tell you the anatomy because you do the procedure so well. But very important that this is the place where you have the maximum width of the epidural space. So C71, C6, C7 is the place from where we go. Even if it is a C3, C4 disc, I can put a needle at C6, C7 and put a catheter to take the drug up to C3, C4. Although if you are in the right place, the drug flows right up to C1, C2 level and there is no problem. And of course, these are all anatomical relations of cervical spine, which are important if you are considering to do a cervical epidural or a transforaminal. And this is the vertebral artery, and this from here the needle goes in. So these are the words of caution which everybody gives when you are planning for a radicular or transforaminal injection. Nonetheless, as I mentioned, we should discuss about cervical selective. It's your choice. You can go for it. So patient lies in a lateral position, C-arm in an oblique position. I'll show you some pictures of that. And once you want to confirm the position of the needle in the foramen, you make it in a, because it's a lateral position, so you'll make it in an AP view. AP view would be like lateral, but this is how you confirm. So the patient is in the lateral position, C-arm in an oblique view, and then you put in the needle and you see the foramen here, so beautifully going into this. And once you make it AP view, you can see that the needle tip is lying in the anterior part of the foramen. So this is how we used to give, and this is black and white because we used to do it in black and white era. So that's why the picture is also black and white. And this is just to show you that just below the transverse process, the needle is going in. That's the foramen, and this is the dye which is spreading in the epidural space. So transforaminal or selective nerve root block in the cervical region. Simple, but as I said, that you have to be cautious while injecting. Every 0.5 ml of drug you should keep aspirating, because there are very high chances of the the the, the needle being moved inadvertently and moving into the vessel. So every 0.2, 0.3 ml, keep aspirating and injecting, keep aspirating and injecting. You are safe, no problems about this. And you can do at 2 levels depending upon whether the exiting route or the traversing route is being compressed. And 2 levels of cervical transforaminal will do the job for you. Lesser amount of drug, and you get fantastic results in these patients. So this is the lateral part of the lateral view of the cervical root sleeve block, where you see the needle just entering into the foramen. Once you put the dye, you will see a spread in the epidural space, and that's what you need. Now coming to the technique which we more often use, that's the interlaminar technique, and as I mentioned, we generally recommend C7T1 or C6C7. So you see the transverse process, this which indicates the T1 lamina, and just above the transverse process, which is the T1 transverse process, lies this space, which is between the two spinous processes, and you see it is more radio opaque, right? If you flex the head, you will see it becomes wider, right? Now again, if supposing patient has right-sided symptom, as you saw in the MRI, you can position, you put the needle on the right side of the lamina. You don't have to go in the midline. Or if it is bilateral symptoms, go in the midline. So you can have a preferential spread on one side too. Or there is another technique also which takes the drug only on one side. But herein, the epidural technique also interlaminar, you can put the needle here and you will find a preferential spread on the right side because the patient doesn't have any symptoms on the left side. So why put the drug or more injectates on the left side? So the position of the patient is prone. Obviously, we'll see all this. No, we'll show all this in the cadavers, but the cadavers are not the right people to flex the neck and show all these things. But whatever we can show, we will show. So prone with a pillow beneath the chest and neck, very important. We'll have full flexion position. Not recommended. Sitting position, we used to do in sitting position with the neck in a flex position, but now since we are doing under fluoroscopy, we don't intend to do anything under sitting position. So arms are by the side of the patient, because if you make a lateral view, the shoulder should not come in between. So it has to be like this or hanging, so that the shoulder does not come in between. Slightly cuffled, and again you have to see the movement of the C-arm has to be done, that the parallax is removed, and it may be cuffled or corded, but most often it is cuffled to see the space very well. We inject local anesthetics up to the interspinous ligament and use a 2-His needle. So this is roughly the position of the patient, the C-arm in a dead AP view, or moved cuffled or caded depending upon the parallax between the end plates, the superior and inferior end plate. As I mentioned, this is the place where I'm using. It's a right-sided pathology, so my needle is on the right side, and I give local anesthetic, and then I use my the kit which has a loss of resistance syringe, which has a 2-His needle. So we use a 18 gauge 2-His needle, a loss of resistance syringe, and then I put the area where I have given local anesthetic, I put my epidural needle and keep pushing the piston of the syringe till there is a give way. And once there is a give way, that means you are in the epidural space. Now herein, very important clinical pearls, as I say, that you will first pierce the interspinous ligament, which is a hardest structure. Then you will have a feel of an empty space. There are not much structures there. And then you will reach the ligamentum flavum. So that feeling is very important. Ligamentum flavum is a hardest structure. Sometimes in a diseased patient, there is a thickening of ligament flavum. It can be as hard as a bone. You may feel I have hit the bone. So that feeling of a ligamentum flavum is very important for us. And now you have to be piercing fiber by fiber, and your ears or whatever the feeling when you pierce the needle, it's a very good. The Portex needle which we use, it's a very nice blunt needle, but you can have the feeling. You will feel I pierce one fiber, one fiber, one fiber. There you have to use all your patience and experience, because there you can't give a thrust. You give a thrust and dural puncture. And this is an area where there is a spinal cord there. There is a spinal cord. Don't be scared of it. There is a spinal cord. So you can't just push it like in a lumbar. There is no spinal cord. You can do anything. But here, no, never, ever. So pierce fiber by fiber. And as soon as you pierce the last fiber, the last push, suddenly the plunger will go in. That's the loss of resistance. That's it. Once the plunger goes in, you are in the epidural space. And you have a fairly good, like 2 to 3, 4 mm, which is a fairly good space beyond the dura, and then the spinal cord, which is very close. So dural puncture and then entering hitting the spinal cord, are they very close? So this is how I put the needle on the right side, and preferentially I wanted drug on the right side, and I am getting the drug on the right side. So these are small. When you put the air and when you put the dye after that, you can see these small air bubbles or air vacuoles, which is again confirmatory that you are in the epidural space. And these are the nerves which are being outlined beautifully. So why this is one nerve, this is another nerve. So you can outline all the nerve roots, and particularly the area where you want to put in the epidural is very nicely highlighted. And we use omnipaque, particulate, non-particulate, your choice. But you may not have to give a very larger volume of drug, because the spread even with 4-5 ml is very good, or even with 2-3 ml. And in the cervical epidural space, we avoid giving local anesthetic because of the fear of the motor blockage. So just saline, and the drug, that's it. Saline is just to spread the drug to places where you really want it. And if you, supposing at C71, you don't find the spread to be good, then you can put the catheter. That kit has a catheter also, and the catheter can take the drug up to C2, C1, wherever you want it, and preferentially on the right or left side, everything is possible with the catheter. Transient increase in pain, this is very important, that whenever you're putting these steroids, whether in the lumbar or in the cervical region, there can be increased headache sometimes. Of course, this I'm not going to talk, but if you, yeah, very important that most of the procedures we do sedate these patients because these are sometimes painful and patient may have sudden vasovagal. So all your attention moves towards that bradycardia which is happening. So monitor is definitely put on, and sedation important. Even if it is in prone position, we do give some midazolam, like 2 milligrams of midazolam, which keeps the patient calm, and the possibility of these vasovagal attacks is reduced. So important. So important to sedate the patient, not let them not have a very bad experience. You may not give analgesics like fentanyl. Sometimes a very painful patient, you may have to give those also. But midazolam 2 milligrams, 3 milligrams can do the job. So all these things and infection and other things, you obviously you know the importance of asepsis and should be avoided. Now coming to the next part, which is more important, and you'll get a lot of patients with facet arthropathies. Um, it is pretty high in neck, pretty high, very important, and it's a common source of disability which we generally tend to ignore, or we it is undiagnosed, and like most of the patients, मेरे को cervical spondylosis हो गया तो जा भाई जा जाना जा, but they come with the diagnosis themselves without understanding that they may be having a facetal pain. So these are some things which we have to really tell the patient that this is not spondylosis which you are saying. Even a 20-year-old girl will come and tell me कि मुझे cervical हो गया जी, मुझे spondylosis. You must be facing the same thing, and sometimes you get so irritated that you tell them what is spondylosis and all. So facet joints pain, you clinically you know, this is the articular pillar where the nerve, you can see the two branches of the medial branch which is coming from above and below, and this is the facet joint, and this is the articular pillar where the nerves, if you have to do a medial branch block, I'll put my drug here, and if you want to block the facet joint, I'll put my drug into this. So you can see the capsule of the joint, an inflamed joint, and you can see the two nerves. So if I have to block one, I mean like block the nerve supply to one joint, I have to do one below and one above, because there are two nerves which are supplying, not one. So if it is C3, C4, I have to do one below and one above. The two branches have to be blocked, not one, even for diagnostic and even for radio frequency ablation. And again, I don't want to go into the details of these joints, you know it very well, but very important that this syndrome contains axial neck pain. They generally complain of pain on one side of the neck, most often one side of the neck, and extension and rotation of the neck is very painful. And if you deeply tender this area, you will find that there is a lot of tenderness. Whiplash injuries is one of the very important cause of facetal pain. So ipsilateral neck pain, dull pain, and with the movement there is sharp pain. You will have elderly people particularly. They will come, I move my neck and it is very painful. There is a referral pattern also, and secondary to trauma could be there will be a lot of morning stiffness, limitation of extension and rotation. Neural sign nothing much, and you will see on an X-ray or on maybe on a CT scan there is a spondylosis or arthritis of the facet joint. And extension and lateral rotation is very important clinical test. If you do it, and you will clinch the diagnosis that it's a facetogenic, and you can confirm with a medial branch block. So clinically, you may not get much information on an MRI or anything of that sort, but yes, clinically, if you do these two basic tests, you will find that it is a facetogenic pain. But there is a referral pattern also, like in a C2, C3 facet pain, you may have a referral on the occipital region, and this may be sort of mistaken as a occipital neuralgia. C4, C5 goes in the trapezius and just below above the scapula. C6, C7 goes up to the scapular region. C5, C6 again in the scapular region, and C3, C4 is by the side. This is just to give you a rough idea, because you don't have a support of an MRI or a CT which will confirm the diagnosis. So if this is the referral pattern, then you can plan your medial branch block according to the referral pattern and give one below and one above and confirm the diagnosis and go for a radio frequency block. So, as I mentioned, the articular the pillar of the articular process is the one where we give these. This is to show you the facet joint. This is the lamina, and this is the area where the medial branch is there, and uh, you can see that this is the intra-articular facet joint injection. These are the facet joints and entering into the facet joint. So sometimes if you are suspecting a lot of inflammation intra-articular, but more often if it is a facetogenic pain which is radiating, you go for a medial branch block and subsequent. This is again uh, intra-articular, 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 confirm under lateral imaging, and then the medial branch block where you just have to put the needle on the articular pillar and give 0.2 or 0.1 ml of local anesthetic and confirm the diagnosis. Once confirming the diagnosis, you can do diagnostic, as I said, 0.3 ml, not more than that. You're putting your needle here and giving 0.2, 0.3 ml of local anesthetic. Patient immediately will tell you that yes, he'll be able to flex and extend and rotate the neck without pain, and that's the candidate for a radiofrequency ablation later on. So, which, as I mentioned, we will see this when we are doing the cadaveric workshop. You can also use the posterior approach. Generally, we use a lateral approach. A posterior approach will give you multiple joint levels, and you can do multiple facet blocks in the posterior approach. Again, when we do the cadaver, we will show you how you can visualize the facet joints, multiple facet joints in posterior view. This RF ablation, this is the RF needle at the articular pillar, and you then go for two needles, and you go for a standard radio frequency, no role of pulse radio frequency, standard radio frequency, and up to the temperature of 80 degrees, starting with 50, 60, 70, 80, you burn the nerve and you will find fantastic relief in such patients. Again, showing you middle branch of various areas. Thank you so much. Again, if there are any questions, we can take it.
What when you are giving epidural cervical, do you make the patient Trendelberg?
Not Trendelberg, just to flex the neck.
Flex
If you put a pillow beneath the chest and a small pillow beneath the forehead and flex the neck a little bit. Not generally a Trendelberg, not a Trendelberg. Flexion gives you a better better space. The width of the space as well as visualization of the space is also better in a flexion.
So, do you use a lateral shoot for cervical, or you just do it
basically-
on AP?
One should always use a lateral to see the spread of the drug, whether it's in the interior epidural space or posterior, and the position of the needle. But the problem with cervical is that the shoulders generally come in between. So if you are good, if your radiographer is good in showing you a little oblique sometimes, not in dead lateral, but little oblique, you should show, you should do it. As a beginner, definitely a lateral position is on. But otherwise, in an AP view, you can see beautifully the roots and all, and everything is so beautifully visible. Our endpoint is not epidural. Our endpoint is the roots, and which you can very well see if you put in like little bit more saline and drug, you can see those roots. Once the endpoint is there, it's okay. But as a beginner, I would always recommend that you should go in a lateral position once you are done in AP view.
And sir, what about when you are injecting the drug, or when you are first selecting the level? Do you use C7D1 or do you prefer C6, C7?
Depends again on the visibility. So C71 of course is visible always, but supposing I am at C4, C5, which is the most common area where the disc bulges, so I would prefer to go at C6, C7. Equally okay. But C71, sometimes you may have the drug going down to T3, T4, T5, and it doesn't go up, so you may have to use a catheter. And catheter also, the navigation of catheter sometimes becomes difficult. So I would prefer C6, C7 most of the time.
Okay.
But in case I am stuck, or it's a very, very obese patient, and that's the only place which is visible, I'll go at C70. So my preferred place would be C6, C7. We can have one.
Thank you for beautiful lectures. You continued both, and then cervical is actually one procedures we generally don't do. And I would invite Professor P.S. Chandra. He's the unit in charge of our unit, and he's come here. So it's a pleasure, sir. Thank you. And now I would like to invite Dr. Ashish Tandon, who's AIMS alumni and is practicing consultant. Sir? I mean, अच्छा वो epidural उसका मैं I thought sir might be थोड़ा सा tired होंगे. Continue. So yeah, let's put it.
It's okay that we continue? क्या करें, रोजी रोटी है ना.
अरे इसमें कौन से फाइल में रखा हुआ है? Just
Epidural and
oh,
so
fine.
if you have any questions, please come out. I think
Yeah,
आप लोग सब करोगे तो मजा आएगा अगर सवाल पूछोगे तो. जी जी सर, आप तो मेरे टाइम भी थे ना.
I know, sir.
नहीं, I'm an antique person. I left 19 years ago. Were you there?
I was there.
You were there.
I was there, sir. I met you many times.
Yeah, yeah.
also. Sir, very excellent lecture. I couldn't come for the entire lecture due to. I see that you burn when you do radio frequency ablation. You burn for 240 seconds, sir.
Yeah. 60 seconds. So we start with 50, 60 seconds, 60, 60 seconds, 70, 60 seconds, 80, 60. But
So
different
you
temperatures.
give 4 cycles with
4 cycles.
different
1
temperatures.
minute each.
Okay, sir. So you start maybe with 60 degrees for 60 seconds.
No, I start with 50.
50 degrees.
I'm a conservative person.
Hmm.
So start with 50. So once you burn with 50, then subsequent pain
Hmm.
of that burning is reduced. Although these patients do need sedation when you're
Hmm.
doing the burning process. So 50, wait for a couple of minutes. A little bit of nerve is already ablated. Then you go 60, less pain. But as you increase the temperature, the pain of injection, pain of ablation also is there.
So you do it under sedation, sir, or we can do it without sedation?
No, we do under sedation. It is pretty painful.
Okay.
Or else, once you have identified the nerve, you can give some local anesthetic and do it. Just about 0.1 ml of local.
And that's what normally people do.
Normally
They just
everybody
give some
does.
local anesthesia.
No,
and then they do.
I was talking about trigeminal where we do under sedation.
Okay.
Trigeminal RF we do under sedation, but these facet joints we do on after giving local anesthesia.
Okay, sir.
Identifying the nerve, everything done, then you give stimulation, motor, sensory done, then you give 0.1, 0.2 ml of local anesthetic, and then you burn the nerve.
Okay. Thank you, sir.
So the last part of this for the morning is epidural and caudal blocks. Again, important topics because as a pain neurosurgeon, I mean this is a different category altogether. Neurosurgeon relieving pain, very important. That you will start with these basic things only and then graduate. Don't move on to high fancy things. Start with basics, get the results because we also did the same thing. I mean, like these caudal blocks, we started. It's a history of it now. When we used to do caudal blocks blind, the results were 90%. Now we do under fluoroscopy, results have come down to 60%. But that was a different generation. You know, giving them 40% relief was considered, I mean, they used to have so much of satisfaction that they said, हो गया सर, ठीक है. अब 40% पे तो खुश होते ही नहीं है वो लोग. So things have changed. But the same injection given blind, I still remember 40 years ago, हम ऐसे कहीं पे भी ओपीडी में भी लगा देते थे. ओटी तो मिलता नहीं था, सर्जन देते नहीं थे हमें ओटी. तो ओपीडी में लगा देते थे. पेशेंट अगली बार आया बिल्कुल ठीक सर, कोई प्रॉब्लम नहीं है, सब पेन खत्म. पर अब वही इंजेक्शन फ्लोरोस्कोपी अल्ट्रासाउंड सब कुछ करने के बाद भी 50% रिलीफ मिला सर, अभी तो और मिलना चाहिए. शायद प्राइवेट प्रैक्टिस में भी थोड़ा पैसे लेके करते हैं तो उनकी एक्सपेक्टेशन बढ़ जाती है. So basically, like whenever you want to give these epidurals, which are very important for pain relief in radiculopathies, you have 3 approaches. We have discussed the interlaminar for cervical, interlaminar for lumbar can also be used. The commonest which came up in the after maybe 1995 is the transforaminal, also called the selective nerve root block, also called the root sleeve block. All are same, different names. and then the caudal approach. 3 approaches. You can enter into the lumbar space, and you can do lumbar these epidurals, and you can see on this diagram. So this is the epidural space, very small epidural space. This is called the epidural steroid injection. This is the nerve root block where the dorsal root ganglion, and you are instilling the drug in this area. This, of course, is the facet injection, and this is the medial branch block. So very beautifully, and the structures you can, the ventral rami, the dorsal nerve root, the traversing nerve roots, the disc, the arterial supply of the disc, and the medial branch which supplies the facet joint. This is a shoot which goes into the facet joint. Beautifully explained here, which you can really get a grasp and then follow it up. So in the 1990s, we started with sitting position procedures, and I did a study with the orthopedics department in 1990 on lumbar epidurals in sitting position. We had CT, MRI both. At that particular moment, we were using more of CT scan to diagnose. MRI was just coming in; it was a little expensive. So the criteria was no neurological deficit, radiating pain, conservative treatment, 4 weeks failure. I mean, the orthopedic surgeon used to load us, ये ले 10 पेशेंट ले, तो हमने 100 पेशेंट की स्टडी करी, उसने 20 दिन में सारी स्टडी खत्म कर दी, 10-10 पेशेंट रोज के. And that was a blind epidural which we used to do in sitting position. And as you see at L3, L4 space, the same syringe which we talked about, the same needle, but again by experience you go. Now this is a wider space, sitting position becomes more wider, and the interspinous space also becomes wider. And this is what anesthesiologist does every day for his anesthesia practice. Same thing, but instead of local anesthetic, we give steroids. And this we used to do in 1990s and 2000 when we were just not starting, but we were into the practice. But like in AIMS, no OT for me, no fluoroscope. The surgeon used to grab the fluoroscope and give me in the evening at 6 o'clock or 6 o'clock in the morning. तो अपने इंटरेस्ट से करते थे, बट मिलता कुछ नहीं था. पर फिर दोस्ती करी सर्जन से, एक दिन ओटी मिला, एंड दिस इज हाउ आई ग्रेजुएटेड टू मेक ए पेन क्लिनिक इन ऑल इंडिया इंस्टीट्यूट ऑफ मेडिकल. एम्स में भी इतना आसान नहीं होता काम करना, काम करने वाले को भी मुश्किल होती है. एनीवेज, सो अगेन the 3D structures which you can see here becomes 2D, and this is how you see this 3D structure. But you can see the nerve roots and the spinal cord and the interspinous area. So you put your epidural to his needle through the interspinous space and loss of resistance, and you see the spread of drug. Now the basic disadvantage of this lumbar epidural approach was that once you put the dye, you will see it going linear. हमें तो इधर चाहिए, we want it here, we want it to coming here. We never used to get it. We used to put in a lot of volume. दवाई डाली 20 ml saline डाल दिया, दवाई डाल दी, उम्मीद किया कि पहुंच जाएगी. And we used to go close to the disc. So L3, L4 या L4, L5 were the areas preferred. If it is mostly L4, 5 disc or L5, S1. L5, S1 के लिए हम लोग caudal से जाते थे. We used to go through caudal. But for L4, L5, L3, L4 or L4, L5 approach was used. But when you used to see the spread of the drug, it was like a linear spread. And if you give more dye, some dye may go into the foramen. So that's why this particular technique was abandoned and we moved into transforaminal. But yes, we have historically used it, and we have used it with very good results. That study which I have quoted, we published it in 1993 in one of the index journal, and that had a success rate of, I mean, like 3 months relief of patient VAS score below 3 was 88%. I don't know the reason why we don't get similar results now. The same drugs which are available now were available then, but the results were tremendous. The quality of life, the pain, the mobility, everything improved. So this is how times have changed, but obviously this technique I would not recommend unless you are really driven to the wall. And you again, I would like to highlight a story. Like I joined practice in 2005, and before that the orthopedic surgeon used to put the patient on the table and call anyone, अरे तू इधर आ यार एक बार epidural लगा दे. तो उसमें लगा देते थे, वो भी बिना MRI देखे, एनेस्थेटिस्ट, और पैसे लिए 1500 चले गए. So one of the patient, again important to tell you, one of the patients sued that orthopedic surgeon, and that study saved him, because that was published study, and he sued that this procedure, because he was from America, so he said this procedure should have been done under fluoroscopy. It was done blind. That time it was blind only. So, and he did put the drug in the arachnoid space, in the dura and subarachnoid space, and I have had adhesions and fibrosis and arachnoiditis after that. And he proved by, in collision with a radiologist, he made a new, I mean, it's important to tell you, he made a new MRI which showed evidence of arachnoiditis. So this surgeon had a tough time, but my study proved that this can be done. This was a blind study, and we used methylprednisolone, and the results were good, and there was no enlargement, and he came out because that time they were more conducive to doctors, listening to doctors. So he got away, but you got to be careful. These things can happen. So now is not the. I mean, basically, I want to highlight that now is not the time to give blind epidural injections or blind caudal. It should be done under fluoroscopy and should be recorded also. Take pictures and give it to the patient. That देखो मैंने ये दवाई वहाँ डाली है. We used to take printouts earlier, but अब हम mobile पे picture दे देते हैं उसको. So these are some of the indications. Of course, the commonest is lumbar radicular pain, lumbar canal stenosis, pseudobulge and spondylolisthesis causing pain, post-herpetic neuralgia, because again, it's the dorsal root ganglion where the herpes attacks and causes inflammation. Facet hypertrophy, again, facetal joints, when they are hypertrophy, they press the nerve, and that again results in radiculopathy. Post-laminectomy syndrome, I will rather not speak much because you know this problem very well, and we try our best, but sometimes it works, sometimes it doesn't. But this is one condition where these can be used, and even a compression fracture, which is sort of a causing a pressure on the nerve and causing radiculopathy, you can use it, but your steroid should be lesser in volume, in particularly when there are patients who are osteoporotic. Transforaminal approach therefore came in because once you didn't have these good results, and transforaminal approach came in, and here you can see this is like the Camden triangle, and you can beautifully see the nerve being outlined, and this was the area where I wanted my drug to be. I don't want my drug in this particular area, and this is bathing the nerve at the interface of the disc, and this is how you do it. And Camden triangle, safe triangle, posterolateral approach, ultrasound guidance we have started, but we are still in a learning phase, and we can see the foramen, but again at the moment we are confirming it under fluoroscopy. But maybe 4 5 years from now, it's quite deep in. So for an ultrasound, the probe, even if it's a high frequency probe, to visualize the foramen is little difficult. We have reached up to the facet joint. Facet joints can be clearly seen under ultrasound, but probably it will take some more time to see the foramen under ultrasound guidance. And as I mentioned, all the three names, the transforaminal epidural steroid injection, selective nerve root blocks or root seed block, this is the pedicle which I said, and uh, this is the nerve root, and you see the needle there which goes in. So this is going into the safe triangle or the Camden triangle, and you can see the spread of the drug in this area. And this is what you really want in a transforaminal epidural steroid. I think you are going to talk about it in detail. That is fine. So again, to show you the Scotty dog, our famous Scotty dog, the superior articular process, the inferior, the foramen over there, and the 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 medial branch is blocked here, and the nerve is blocked here. This is the branch which is coming and supplying the foramen. Again, I'm not going to highlight this, but basically the needle should be pointing towards this, and it has to be a tunnel view. You know, whenever you are putting the needle, it has to be a tunnel view, so that you see only the bevel of the needle. You don't see the needle. So if you can bend the needle tip a little bit, if if you bend the needle tip, there are two advantages. One, that your tip of the needle will not go and hit the nerve. It is bent. So just about 5 to 10 degrees bent at the tip of the needle really helps you in navigating the needle also. So once you are in the foramen and you just rotate the needle, you are entering into the foramen and you are not hitting the nerve. So always whenever you are using the needle, just bend it a little bit. Again, in the cadaveric workshop, we'll show you how much bend. Just the 5 mm tip of the needle has to be bent so that it enters into the foramen. The ideal dye spread is like what you see here. This may not be a very ideal spread, but this is an ideal spread. Again, this is a very ideal spread. So this is not my target area. The epidural space is not my target area. My target area is below the pedicle, at the interface of the disc, and the nerve root. Cervical epidural injections we have mentioned, but I'll just go a little bit in details about this. I think we have covered all this, and C7T1, and we have done this. And you again see the spread on one side. Now, a word about the caudal epidurals. The whole story of this epidural started with a caudal epidural because this we were using for perineal anesthesia, and very simple. The two corneas which we used to feel, and we used to put our needle between the two corneas, and you enter into the epidural space. So the drug can reach up to L5S1. If you put a catheter, it can go up to L4-5 also. So you can use this technique now under fluoroscopy, using a 2 His needle and then putting in a catheter. You can go up to L4 region 2. But again, you have to be aware of the anatomy. Like this is the S1 root, this is the S2, S3, and you may have an advertent nerve root lying in the epidural space. Also, you got to be careful. But this is the area from where we go. That's the coccyx. This is the S5C1 area, and these are the two corneas which you can feel. Otherwise, you can see under ultrasound also and under fluoroscopy also. So basically, you feel for the two corneas. You can put your finger here. You will feel the tip of the sacral hiatus, and by the side of your finger, you will feel the two corneas. And then you have to first put the needle a little oblique, and then you have to make it totally parallel to the skin, and you will enter into the epidural space. Again, you got to be careful that the dural sac is here at about S1 level. So don't push in the needle much. I mean, after 40 years, I must have had some complications. So I have punctured the dura also while giving caudal epidural if you're using a longer, but couple of times only, and no problem, nothing much happens. But you have to be careful that this should not happen. And this is again to show you a diagrammatic representation and the dye spread. So the dye, you can see the dye coming out. This is not a good sign because there are foramens in between S1, S3, S4, 4. So the dye is coming out through S4 and S3 foramen. So all my drug is wasted now. It will come out through S3 and S4. So if I see the dye like this, then I'll put a catheter and take my catheter up to this place. This is the L5S1. So my drug has to go to L5S1, L4-5, not here. So if I see this picture on my lateral view, always done under lateral, caudal epidural, I will hold on. No, I can't push in the needle much because of the dura. So I'll use a catheter. Put the catheter will go here, and then you can push in the drug as much as you want. So this is how it appears, the needle in this position, then going parallel, and you can give the drug up to L5 or even L4 in the caudal root. Ultrasound guidance, we have been using it. This is one particular block which can be very nicely and clearly done under ultrasound guidance. And in ultrasound guidance, you can see these are the two corneas, and this is the sacral hiatus. This is the ligament, this is the sacral hiatus, and you can see the needle being pushed in through the sacral hiatus, and you will find that you won't be giving dye in this. You will just see the needle. So that's again, like for people like us, unless you see the dye spread, you are not convinced. So again, you have to put a fluoroscope to see the dye, because as I said, the dye may spread to S3, S4. So ultrasound is good to put in a needle, but to see the spread of the dye, you will have to use a fluoroscope, because then only you can make out. So caudal roots are good, but as I said, if the S4 and S3 foramen are big, most of your drug will pass through those foramen and enter into that area where you don't want your drug to be. So it's simple procedure. You put a catheter which will go up to L5, L4, and you can then see the drug spreading very well. So a typical Christmas tree appearance is seen when you put in a fluoroscopy, but we are not interested in that Christmas tree because that's the nerves of S1, S2, S3 which are seen. We want the drug to go to L4, L5, and that's how this caudal can be used. So for the beginners, not a bad idea to, if it's an L5S1 disc, to start with caudal. You'll get fantastic results, and then move on to transforaminals, and then slowly and slowly come to the neck also. No problems. Are you confident now? Wonderful. Thank you. Sure. Oh, for the sitting.
Dural puncture. How frequent is it? Is it okay to have a neutral position, or you need to have a proper flexion, which we do for a lumbar puncture for epidural blocks?
For epidural also similar position to the lumbar puncture. Only thing is that the flexion increases the epidural space, so you have wider epidural space. But say it again. Maybe I'm
I
not
mean, when
under-
you flex more,
Yeah,
maybe the dura
comes
comes
up.
up.
Yeah.
So the chances of epidural puncture increases. This is theoretical
Yeah, this is
because
possible.
once it has happened
No,
and
no,
then I've
it
gone through the
happens
literature.
also. Since now it's a obsolete technique, we don't do any epidural, at least me, anesthetists do, but not me. So we are not doing any sitting position epidural now. It was only in the past in the 1990s. But yes, you're right. The possibility of dura puncture are much, much more when you are doing it in a more flex
More
position.
flex position.
Yes, certainly. Certainly. But in a cervical epidural space, more flex position causes an increase in the epidural space. So that's a better
Okay.
technique in the flex in the cervical space. But in the lumbar, definitely there is a more chance. But that's a obsolete technique now. Only anesthesiologists use it for anesthesia. Any other questions?
If no more questions, sir has a question. Sir, there is a question from.
Yes.
So between epidural blocks and root blocks, sir, in terms of efficacy, which do you think is better?
Sir, see, basically, you have to go by the pathology. So if I am having a patient with a disc herniation causing radiculopathy, transforaminal or root blocks are preferred. But if I am having a patient with a lumbar canal stenosis where there is a ligamentum flavum hypertrophy, where there is a central canal stenosis also, I would prefer to do both then. Transforaminal may not, because the foramen is so narrow that the drug will not go into that area. So maybe I will use transforaminal, but epidural would have more efficacy because now you're bathing the central canal, the ligamentum flavum, which is causing compression. So a ligamentum flavum hypertrophy with a central stenosis, I'll prefer an epidural. But with a simple disc herniation or even an extrusion causing more radiculopathy, ligamentum flavum is normal, I would prefer a transforaminal.
So other thing regarding lumbar canal stenosis.
Yeah.
So normally when there is severe canal stenosis, we only end up doing surgery.
Yeah.
In your experience, in your huge experience, if you get lumbar canal stenosis, what are the things which improve with epidural blocks?
Right.
Does the neurogenic claudication do they improve?
I will come
or-
to that. Every day we are getting patients 85, 70, 90 years. Life expectancy in India is growing rapidly. And you will have, I think you also in your practice would be having so many patients where you feel helpless. You know, as a surgeon also you feel really helpless. And last night I did a video call from a patient in Hyderabad and he says, last year I was walking like 3 kilometers, now I'm not able to walk. And his expectation was that I do something and I start walking. So first I told him, see, I can only relieve your claudication a little bit. And you can walk for 15 minutes. Don't think that 40 minutes or 1 hour is possible again. So that with that statement also he was depressed. Then surgeons are refusing that I am 85-year-old and you are saying that I can't walk. I said that's a fact. That's the truth of life. But the surgeon blatantly said that this is how you have to live. Fine. If he can't operate, he has got a CABG done, fine. But I told him that I will give you 15 minutes of walking time without pain. He was not happy with that. But yes, coming back to your question, you have large number of patients coming in and you can only improve their quality of life. See, lumbar canal stenosis is one place in 85-year-old where there is a lot of osteoporosis, osteoporotic spine. These steroids can cause more local osteoporosis and more narrowing and of the foramen also. So you got to be very, very careful. So we tell them that, like as I mentioned, I can improve your claudication distance by 15 minutes. You'll have lesser pain. Paresthesia will exist, but your pain will reduce. And I can't promise you how long. But what to do? I mean, I can't just leave these patients. So some of the patients have done very well. Some of the few professors of surgery from our institute have done them, and they are leading a very good life. They come back after 1 year, say, must chal raha hu. But they have accepted that 15-20 minutes is good. So along with minimal amount of like drugs like gabapentin, good little bit of exercises, not very much of exercises, and one repeat injection after every 1 year or 9 months, their qualification distance does improve. I don't often repeat it, at least for 1 year we don't repeat it. But yes, in about 70% of patients we do improve their quality of life and improve the claudication distance by giving epidurals, but I don't repeat it very often. And they do well. But this population is exponentially increasing and a lot of pressure is being felt by you as well as by us because they don't want higher, in fact, their emotional lability, you have to give antidepressants and other things. But this population is going to be our real target in the next few years, which is going to increase further.
One last question, sir. With your experience, when you give epidural versus root blocks and all that, how often do you have to repeat them?
Sir, like in a patient, young patient who has failed a conservative treatment and who has no neurological deficit, right? We take the criteria and we do a transforaminal. I don't repeat it because in AIMS we had a protocol of giving every 4 weeks. That protocol is followed in US, but not anymore in India, because repeated blocks don't do much. They rather cause more damage. But the more important part is that we have to follow a rehabilitation approach. So I tell him that if I am doing a procedure, next 3 months are mine. You have to follow my advice. So slowly and steadily, exercises and all. So therein you don't have to repeat unless there is like 20% patients who I may have to repeat in a younger population. But in patients with lumbar canal stenosis, the effect lasts for 3 to 6 months, and then perhaps they sort of adapt to their changed lifestyle, and they feel happy with gabapentin or pregabalin taken over a longer periods, and they continue. But if I have to repeat it, I'll repeat it after 9 months to 1 year. So our protocol has changed in the last 20 years from 4 weeks, 3 blocks to now 1 block with a proper rehabilitation, and that really works. Psychological, like you improve their psychological status, you tell them to do purposeful movement, but with caution, and everything improves. Because nowadays, everybody is in a rush, but this work from home has really saved them, because you then put them on rest also, and they don't have to exert, and slowly and steadily they improve over a period of time.
I have one more question.
Please.
I keep on remembering this.
These are very practical question, I thought.
So right now, what has happened in the spine market? It's either become a gabapen or a pregabalin driven market, or it has become an implant driven market.
Yeah.
So we see patients, and these patients are on pregabalin and gabapentin practically their whole lives. So now, in your experience, when you give these blocks, how successful you have been able to discontinue pregabalin or gabapentin, or do you feel they have to be continuous as adjuncts?
No. I mean, like younger patients, maximum 3 months. In older patients, we reduce the dose because there are long-term side effects of these drugs. Weight gain is one, and then in an elderly patient, a lot of dementia and other changes have occurred. So we don't prefer to give them over a longer period. So maybe 3 to 6 months we taper them up. In a younger patient, maybe 2 months to 3 months we do give it, but we keep tapering the dose and stop it after 3 months. In an older patient, maybe stop it after 4 5 months, not more than that. You are very rightly saying that it is it's a pregabalin and gabapentin, an industry-driven market now, and a lot of stress is given on these drugs. They do work, but they have not to be continued for a longer period. We have had patients where there is a dependence. They can't sleep. Young patients, they can't sleep once you stop their gabapentin. So very fast you have to start tapering these doses and stop them, because they become so dependent that they keep coming to you for prescriptions. ये देते रहिए मुझे नींद अच्छी आती है. And once they stop, they become very restless, and the whole family gets together. So that's important, that not over a longer period. Lumbar canal stenosis, elderly also, there are lots of long-term side effects, the psychological side effects, mental side effects, and weight gain and other neurological side effects. So I would not prefer to give for a longer period. Even if I give very low dose, like 100 milligrams or 50 milligrams of gabapentin, not more than that. Implant, I think you are the better judge to answer. I can't answer that question. But yes, having said that, these patients then ultimately end up to pain physicians, and those are the most difficult ones. You who have been implanted at very young age. I don't know why the concept of this implant has changed. 25-year-old female having an implant. I don't know. I don't know. That was not the standard teaching. Standard teaching that time, but 20, 25-year-old, 30-year-old with implants, and then persistent pain, and I can't do much. I can't do much about it. And there are a lot of psychological impacts which rule their pain. So, fine challenge all the time.
So thank you, sir. Thank you very much for the. We'll have a question a bit
only
later.
evidence-based medicine. Distal channel blocks is not my cup of tea. Sorry.
Thank you very much, sir, for continuing all the 3 lectures at a time and finishing well in time. So, just before you go, sir, I would like to felicitate Professor Dureja. Sir, we would like to felicitate you, and Dr. Deepak Agarwal to felicitate sir with a bouquet and a memento. Sir, there is a button, you can put it on backside. Dr. Rajesh, I would like to welcome Professor Chandra, who is a vice chairman of this workshop. Dr. Rajesh, to please felicitate with a flower bouquet. Sir, please. Sir, please. I would like to call Dr. Hitesh Gurjar to felicitate our guest faculty, Dr. Ashish Tandon, with a memento and a flower bouquet. वो मोमेंटो दे देना सर बटन ऑन कर दो yeah. So we'll now have a break. We'll have a breakfast and quick breakfast. Please be back as soon as possible because we're already running late. Yeah. So 10 is a time. We'll start sharp by 10. So welcome back. We'll start with our talks straight away because we are already running late. I'd like to invite Dr. Ashish Tandon to guide us through the blocks again, lumbar and thoracic. Mainly lumbar for neurosurgeons. I think he will be telling us the various techniques of doing it. So Dr. Ashish.
Thank you, Ramesh, Professor Chandra, and Deepak, I don't see, and friends. So, this is blocks for neurosurgeons, and I found this interesting.
सर मेरा एक सवाल है सर सर स्पेस में फाउंटेन पेन बॉल पेन चलता नहीं है तो एस्ट्रोनॉट्स ने पेंसिल का इस्तेमाल क्यों नहीं किया लाखों डॉलर बचा था
So it's like we as neurosurgeons, we are driven by technology, and that attracts us. But we need to understand that there are very simple ways and easier ways to get the job done. And many a times in our practice, there is a discordance between our intent and the result that we get. And that is where I feel that blocks come in place. So why do I need to learn blocks? One, it helps clinch the diagnosis many a times. See, we have situations where there are multi-level stenosis, multi-level discs, facet joint pains. So what is the real problem? And what we need to treat is always or many times a question before us. So it helps clinch diagnosis, and nowadays it is definitely a part of the treatment algorithm. So on one side you have neurophysicians managing back pain, then you have pain physicians managing or giving pain therapies, and neurosurgeons and orthopedic surgeons operating on spine. But I think we as neurosurgeons offer a complete set of algorithmic treatment to our patient with correct diagnosis, with conservative treatment, with pain therapy, and finally surgery. So when the patient comes to us, we can give him a complete repertoire of management tools. So that is why I feel that learning spine blocks is very essential. So what are the blocks that I typically use? So in almost all of my lumbar spine cases, I would be using erector spinae plane block. It is one of the easiest blocks. You can use it for, say, a lumbar disc surgery. You can use it for thoracic surgery, any form of surgery. Preoperatively, you give a erector spinae pain block, and the patient's pain would reduce. The second is transforaminal blocks, for which I would be talking. This is the main topic of interest: selective root blocks and transforaminal epidural blocks. This has already been covered, facet blocks. So it could be an intra-articular block or a medial branch block that can be given. Then epidural blocks, again, this has been discussed. So I won't go into the details. Caudal epidural blocks, SI joint blocks. So these are the sort of complete list of spine blocks that we need to learn. Okay. And I think one of the lectures would be on ganglion impar block as well. That is for coccydynia. Again, lot of our patients complain of coccygeal pain, and this is a good sort of treatment option apart from just giving them sits bath. Also, lately I've started using digital manipulation also of the curved coccyx. So I would be focusing more on transforaminal blocks for today. Now, why do we need blocks? Well, there is truly speaking, a poor association between imaging and chronic cases. I'm not talking of acute cases, but of chronic cases. And in only about 15 to 20% cases, the source of chronic pain can be picked up through imaging alone. So this is the data that is in front of us. So just imagine if the patient has pain for more than 6 months to a year. So we, as of now today, we just see the patient clinically or radiologically. And the coherence between the two may not always be true. So as I mentioned, diagnostic indications and therapeutic indications. So for diagnostic, it helps diagnose the source of pain, pinpoints pain generating root or facet, and you have to use very little amount of lignocaine to confirm the diagnosis. At least 70% relief is required to confirm that it is a positive result on a diagnostic root block. The diagnostic value at best is moderate. So what I'm trying to say is that you can't just finalize your treatment based only on diagnostic block. There has to be clinical features suggestive of a particular pain, then diagnostic block, and coherence with the radiological investigation. The frequency of blocks, it can be 3 to 4 per year, which is considered safe, but there has to be a gap of at least more than 2 weeks. These are set of contraindications, including if the patient is on anticoagulant, and very common is antiplatelet. Because we have an aging population, they invariably come with antiplatelet therapy. And then local site infection, pregnancy. Pregnancy these days, we have started using ultrasound, and allergy to contrast or LA agents. Type of steroids has been covered. I truly speaking, I just use dexamethasone because I'll tell you the reason. The dexamethasone particulate size is 10 times smaller than RBCs, and they do not aggregate. But more importantly, we know that there is no difference whatsoever in functional or analgesic outcome between particulate and non-particulate. So we have ample number of papers. So once we know that non-particulate is safer with same efficacy, not shorter duration, then why not use dexamethasone? So that is why I have shifted to dexamethasone for all types of my blocks. There is a rationale for steroid use. I'll not go into that. The sum and substance of that slide was that when you use steroid along with local anesthetic, the results are much, much better. This again has been covered, but I want to draw your attention to one very important aspect, and that is the viscosity of the dye. The viscosity of the dye is higher, so the spread is lesser vis-a-vis local anesthetic and your steroid. So again, what I'm trying to suggest is that suppose once you have taken a fluoroscopic shot with the dye, rest assured that the local anesthetic or steroid that you are injecting would spread much more than your dye. So you will be covering much more area with the local anesthetic. Okay, I mentioned this fluoroscopy versus CT, use fluoroscopy. I'll skip erector spiny pain block, but you can come and discuss with me. It is a pre-operative block and it is excellent for pain relief. Ramesh, you want me to cover this? Okay, there's a talk. So I'll skip all this and I'll go directly to transforaminal selective root blocks and epidural blocks. Okay, so the drug is injected through the foraminal root for blocking the nerve roots along with epidural steroid spillage. So you can be selective for the selective root block, or you can give an epidural along with the root block. when you want to use transforaminal blocks. So what are the indications? The first and foremost is radicular pain secondary to disc prolapse. Now coming to the question which Professor Chandra had asked, sir, we have level 1 evidence as far as radicular pain for acute disc is concerned. And for lateral foraminal stenosis, we have level 2 evidence. For post-laminectomy syndrome, we have level 4 evidence. For failed back, again level 4 evidence. It is an excellent tool for post-herpetic radicular pain. And again, it is an excellent tool for scoliosis causing radicular pain. When I am talking of scoliosis, I mean degen scoli, wherein the patient is coming with pain. You really don't need to attack these elderly gentlemen with long fixations. You can initially try blocks. Now, radiology of the lumbar foramen, that is very important to understand. So, it is an oval structure and you see the patient on a X-ray like this. The height is around 1.5 to 2.5 centimeters and there is progressive widening as you go caudally. So, it's easier to do it caudally. That means at L4, L5 or L5S1, it would be much easier to negotiate your needle. The exiting route is in the superior part of the foramen. So if you look here on this X-ray, the foramen is here. So this, if you are introducing your needle here, this is supraneural. Remember, this is supraneural and this is not the Camben's triangle. The Camben's triangle is infraneural. Okay. So if you look at the Camben's triangle, the base is formed by the end plate of, thank you. The base is formed by the end plate, then the perpendicular is by the superior articular facet and the hypotenuse is by the exiting root. So this is the Camben's triangle. And today I would be demonstrating the long route to enter the Camben's triangle so that you can also learn the needle technique for a transforaminal discectomy. Okay, and so we have a supraneural technique which will introduce the needle here, but an infraneural technique which will introduce the needle here. You can do a discogram, one. You can give a root block, you can give an epidural with root block, and you can then have the needle with the dilator for a transforaminal discectomy. So a lot of things can be achieved. Now another important thing to note is that it is wider, the Camben's triangle is wider till L4-5 and at L5-S1 it tends to become narrower. So what is the relevance of this? The relevance is that till L4-5 you can go transforaminal. For L5-S1 go interlaminar endoscopic. This I am talking about discectomies. So this is important to understand. Now coming to the technique, we have two different techniques. One is parasagittal approach. This is mainly for L5-S1 in my hands. Because there are a lot of bony restrictions, so I don't go the far or long way as we use for transforaminal discectomies. And then the second is far lateral approach, which is my personal preference. So we'll see what I mean. So as far as the needle placement is concerned, you can have it subpedicular, which is the most common, specifically for a root block. Selective root block, you can go subpedicular. Then you have retroneural or retrodiscal. But basically, the best place is to target in here. There is no root and very limited amount of vascular structures as well. Now, what is parasagittal approach or just paraspinal approach? I use it mainly for L5-S1 level. though it can be used for any level. The technique is you place the patient in prone position, part preparation, confirm the level, oblique Scotty dog view. So this is the view you get. So you have, so what I'm trying to suggest is I use this technique for L5S1. So basically for L5 root, that means if I have a caudally migrated L4-5 disc or a simple L4-5 disc with compression of the L5 root, and if I have to give a L5 root block, then I would use a parasagittal approach, not a far lateral approach. The reason is you have the iliac crest, you have the sacral ala, you have the transverse process. So negotiating the needle from far off tends to become more difficult for L5S1. And that is why I use the parasagittal approach or the typical approach. I use a 22 gauge needle with a gentle bend, as was mentioned by Professor Dureja, and you can place the needle in the safe triangle zone, which is supraneural at L5S1 region. So the needle, as you can see, the needle is bent here, and you can place the needle just subpedicular, but not at L4-5, but at L5S1. Okay, this is again demonstration of AP and then gradual turning to show the difference between AP and the oblique Scotty dog. The most important is that the facet joint need to be parallel, that and once you achieve this, you don't need any more obliquity of your C-arm. So that is quite important. And then you start the needle from, you enter the needle, skin entry is somewhere here, and then you go up. So as I was highlighting the infraneural approach, look at this photograph. See the amount of vascular structures even when you are approaching supraneural. And that is why infraneural limited number of vessels, and root is also far off. So injuring the vascular structure or the root is quite limited. And this is the picture. So here, as I mentioned, for L5S1, I typically use a parasagittal approach to get a selective root block. Now the question is, suppose if you have a L5S1 disc, which root do you want to block? S1. So for L5, for L4-5 disc, you are blocking in here. S1 root you need to block further down. So you need to learn a S1 root block as well, because L5S1 is one of the commonest discs. So you need to block S1, and for L4-5, L5, but if this was another question asked by Professor Chandra, when to use epidural and when to use epidural with transforaminal. So for me, if the patient has a lot of axial pain associated with radicular pain, I would add a epidural with the transforaminal, because just pure transforaminal is not going to relieve his axial pain. Okay, so again, because it's a 3D structure and these are the 2D pictures on C-arm, we need to have AP and lateral shots to confirm where the needle is, and then you inject the drug. Okay, so this is just to demonstrate the confirmation of the position, and this is a good dye flow on AP and on lateral. Okay, so this we would be demonstrating today on the cadaver. Now, this is my favorite approach, and this should be a favorite approach of all our all the neurosurgeons. And the reason is because we have to take today or tomorrow a transforaminal endoscopic surgery. So to introduce the needle, you can't use just the parasagittal approach, because you need a long needle to enter into the disc, on which you can push in the dilator and then do an endoscopic transforaminal discectomy. So it's easier to place the needle in the lower part of the foramen, when I go far lateral. It is not very difficult, and you can push the needle almost till the medial pedicular line. So you need to understand that with this approach, you can really push it medial, and with one shot, I can give 2 root blocks and an epidural block. So with one needle placement, I can achieve all 3 targets. Okay, I have already covered this. What is the disadvantage of lateral approach for L5S1? To get the needle in here becomes very difficult because of the iliac crest. To quickly show you, on AP there should be no parallax. That's very important. These should be flattened. So no parallax on AP. The spinous process needs to be bang in the midline. Okay, this is what Rutan has suggested. He is one of the masters of interlaminar and transforaminal endoscopic surgery. So I use the same. If you want to give a transforaminal block at higher level, start at the spinous process. So your marking has to be on lateral at the spinous process. For L4-5, L5S1, or say for L3-4, L4-5, it can be the hump of the facet joints. So again, I'll sort of elaborate on this during the cadaver demonstration. So this is the lateral marking for the lateral approach for transforaminal needle placement. Tip of the spinous process for L1 to L2-3 and L3-4, L4-5 up to the laminofacetal junction. Okay, so this is how we mark it, and then X-ray sort of confirms you need to be just above the iliac crest for L4-5, and a few cases of L5S1 you can sort of place the needle there. Once the trajectory is certain, you shift to AP view. So the needle is going in here. It is infraneural at the disc level. So most of our pathology is when we are doing transforaminal blocks is discs. And when we operate, we see that the root is inflamed just beside where the disc herniation happens. So it makes sense to deposit the drug near the pathology. And this type of entry helps me pushing the needle there. Okay, so the needle is inserted. I use a long needle. Today I think we've got hold of these needles, and then I enter into the Camben's triangle. So for a block, I go a little above the disc level. If I want to do a transforaminal discectomy, I'll go into the disc. So we can reach up to the medial pedicle line. We can reach near the anterior part of the foramen, so very near to the pathology. This is an excellent way to reach to the pathological area. We can also go supraneural if you want to, and then you inject the dye to confirm. So you'll see that, you know, here this is one root, and then you can see some spillage into the epidural space as well. Okay, so this is just to confirm where the needle is, and then you can also go with just some angulation of the needle into the disc, and you can do a discogram as well. So with the same needle, just with little maneuvering, you can enter into the disc. Drug used has already been discussed, so I'll not waste time. Again, I have mentioned my reasons for using dexamethasone. I use 2 to 4 milligram of steroid. Okay, so complications, well, you can cause bleeding, especially in elderly or those who have been on antiplatelet. You'll be quite aware. Infection, allergic reactions, nerve injury, transient numbness, dural punctures. You can have side effects of steroids or the drug, and rarely paralysis. So this is the meta-analysis of transforaminal epidural and root block radicular pain secondary to disc. As I have already mentioned, level 1 evidence of benefit at 6 to 7 months. Pain secondary to central canal stenosis, level 4 evidence, so not a very good evidence as far as central canal stenosis is concerned. This was again one of your questions, sir. And for failed back, again, not a very good evidence for epidural steroid. Okay, so blunt needle with infraneural approach has the highest safety. So the take-home message would be, it's very important technique in one skitty. Please remember, you are doing Kawase approach, you are doing all sorts of aneurysms. The learning curve for these blocks is not steep. Just 5 cases each, you can easily go back to your centers and start doing it. Okay, so it is not difficult. It's best for radicular pain secondary to disc prolapse. But you can add to other indications as well. Learning curve, as I have mentioned, is not steep. Due diligence for safety is required. You can't take it easy. Also, try and inform your anesthetist that you are taking up the procedure, so that in case something goes wrong, he is well aware. Also, do it under monitoring, secure a line, and keep the blood pressure optimal. Okay, so this was the part for transforaminal transforaminal blocks. If there are any questions on this.
So, sir, Deepak, I would be putting I take 0.5% bupivacaine, which is preservative free, dilute it to 0.25, and then inject 1 to 1.5 ml, depending on the indication of the drug.
Suppose you have to target all the three, I mean the root above, root below, and the epidural, then also just 2
Then
cc.
1.5 ml.
1.5.
Because the amount of dye that you use is just 0.5 to 1 ml to see all those structures.
Okay.
And as I have mentioned, that the drug spread would be much more. So it is about 1 to 1.5 ml.
And you mentioned, then you repeat it also?
I do repeat it. But not before 3 to 4 weeks after the first shot. And in case if he has got significant relief with the first, and then he has had moderate recurrence, not willing for surgery, I repeat. Okay. Yes. So when with particulate matter, you find lot of adhesions, you find certain granulomas. You'll see on, especially with endoscopy, you are able to see white particles. With non-particulate, adhesions are there, but you don't find those granulomas. But the risk, and it's well mentioned in literature, risk of infection, risk of adhesion is higher when you are doing surgery after a transforaminal blow. So it's not that it is without any problems. It has its own set of problems.
Then we are planning for selective injections.
Yes.
And if patient having sensitive symptoms, then also we can give the type of injection.
Okay, so see, sensory symptoms are the least to respond. Okay, so you are doing mainly for pain, not for any motor deficit or for sensory symptoms. In fact, that is a relative contraindication, because if there is neurological deficit coming in, you tend to go away from blocks. Until unless there are comorbid illness, very elderly patient, then you do it. As I mentioned, the literature says that there is no difference. There is no difference.
Okay, Ashish, you can continue with the next talk on trigeminal.
Trigeminal. Okay.
10 to 15 minutes.
Yeah. Okay, so as far as the numbers are concerned, the reason why I've got into RF lesioning is basically the patient does not want MVD. I used to counsel 2 to 4 patients every month for MVD in my clinic, and they were not ready. And since I have shifted to RF lesioning, I am doing 1 to 2 per month easily. So that is the numbers in my clinic. Maybe they must be much higher in other centers, but when you go back, if you start doing RF lesioning, your numbers would increase. And I'll show you the data that it is very good, not as per the gold standard of MVD, but it is excellent. It gives an excellent outcome. So in the interest of time, I'll skip all this. The treatment options that we have, the drugs that we have, carbamazepine, lamotrigine, and phenytoin. Glycerol rhizotomy is almost given up. Balloon compression is still there and very good, especially for V1. Percutaneous radiofrequency lesioning is the workhorse as far as non-surgical techniques is concerned, and we have radiosurgery. So this is just my personal algorithm. So many can question this. The first is failure of medical treatment. The second, as I have mentioned in red, is patient preference. If the patient doesn't that, look, doctor, I don't want MVD, drugs are not working, there's a lot of complications, please do RF, I won't say no. Aged patients, medical comorbidities, it is a well indicated procedure, and recurrence after MVD. So these are my indications. The contraindication being V1, and in almost all cases of V2, V3 neuralgia, I would take up RF lesioning. So it's all about knowing the anatomy. Basically, we ablate the ganglion just above the foramen ovale. So it is in the anterior part of the petrous temporal. It's a significant size, 7 by 4 millimeter. And it is at the level of the posterior root of the zygomatic arch. So when you're entering here, almost at this level, you'll find the foramen ovale. This is to just show the foramen ovale and the third division, and we are getting the needle through here into the ganglion. This is to show the inside view of the skull. You need to understand that foramen ovale is very near to other foramen as well, including foramen spinosum and the carotid canal. So it's not that you cannot damage. People have also reported injuries to optic and supraorbital fissure structures. This is the view that you get through the exoskull view of the foramen, again very near to other foramen and other vascular structures. So what are the structures around the foramen ovale? So just behind the foramen ovale, you will have the internal carotid artery and middle meningeal artery, and then you have behind that the internal jugular vein. So This photograph is basically to show you the uh, uh, relative anatomy of the ganglion to the various divisions. So V1 is much higher in the ganglion, V2 in the center, and V3 is lowest. So where your needle ends up depends on the type of neuralgia the patient has. So if the patient has V3, you can still stay below the clivus, but if it is V2, you need to reach up to the clivus. This is a 3D reconstruction that I got. If you look the foramen ovale, this is the mandible, this is the third molar here, and in between the two, we have to place our needle. So this is just to show you the various rotations on one side and then on the other side. So this is where you need to place your needle. So you have markers. You need to go medial to the mandible and lateral to the third molar. So coming to RF ablation, it is either fluoroscopic guidance, or in certain cases you need to use CT, because there we have various types of foramen ovale and there can be calcification. So in those cases you need CT guidance. And we have a 90% relief immediate with a recurrence of 20% at 1 year. So this is a very good result. You have 90 to 95% with MBD, with a lower recurrence at 1 year definitely, but this is also a good result. So I use either 22 gauge 10 centimeter RF cannula or a 15 centimeter RF cannula through the foramen ovale. This cannula is sort of insulated. The tip reaches besides the ganglia. I do a test stimulation. The patient is awake at this time. There is paresthesias or pain is stimulated, and there is motor stimulation also. The jaw tends to open when I stimulate. And then I use a RF lesioning 60 to 80 degrees for 60 to 90 seconds. I generally give 2 shots. So one shot, I start with a higher level, so V2, and then pull down a bit to V3. So traditional fluoroscopic guidance, 3D CT is not usually used. Neuronavigation, rare. So I have never used neuronavigation. So what is the trajectory? It's 3 centimeters lateral to angle of mouth. Now why 3 centimeters? Because medial to that you have the facial artery and vein. So you don't want to damage that. The trajectory is, it's medially directed. You feel the needle with your finger inside the buccal oral cavity, inside the buccal mucosa, and it travels to the mid-pupillary line. So on lateral fluoroscopy, first you see the hard palate, then junction anterior 2/3 and posterior 1/3 of the hard palate. That is where nearly where the needle has to cross, and then it has to be within 1 centimeter of the sellar floor. So what I mean was, the needle goes from somewhere here and it enters the foramen ovale about a centimeter below the sella. So this is the picture to show you. So look at the hard palate. This is the clivus, no parallax, the sella seen well, and it is at the petrous apex, and then you get into the foramen ovale. So electrode position I have already talked about. The second division is nearly up to the clivus or little higher, and the third division, this is the clival line, would be lower down. I'll skip this. So quick demonstration of the technique. The setup, you need a RF generator, you need fluoroscopy, and you need a team with anesthetist. You just appreciate there's a small sheet kept here to give mild extension, oxygen line, the lateral fluoroscopy. So on lateral, again, no parallax, not too extended. Sella needs to be sharp and clear. You see the clivus, you see the petrous temporal and you need to see the hard palate. So all these structures need to be visualized. It's very important. Um, Again, this is just to show you with some extension. Sorry. So here I mark, this is at the lateral canthal line, 3 centimeters lateral to the opening of the oral cavity. Here it is to show that there could be arteries medial to that. So give local with one finger inside the oral cavity, and then 22 gauge needle. Here I hope you are able to see the insulated needle. So the tip here is non-insulated. The rest of the needle is insulated because your electrode is going to go. So you don't want to burn any adjacent structures. So 10 or 15 centimeter needle, I use a 5 mm active tip. So here the needle is being placed under fluoroscopy and to reach up to the clivus. Okay, this oblique submental view is extremely, extremely important. Why? Because if you are getting the foramen ovale, then it is just end on straight. You don't need to do anything. So get a good submental view. Till you don't get a good submental view, try not to start. So work your way to get a good submental view. Okay, so this is the foramen ovale. To just show you the whole perspective, this is the maxillary sinus in here. You see the mandible and you see the molar and the lateral part of the orbital wall, and there would be the foramen ovale. But it's not, this I have brought in is a good photograph. In many elderly with osteoporosis, it's not that clear many a times. So you need to sort of play. Once the needle is in place, I give a 1 millisecond pulse of 0.3 to 0.5 volts, which is the test stimulation. Causes paresthesia in the division of the stimulation. It also sort of tends to open. Now look, when I'll give the stimulation, there is opening of the oral cavity. So that is what happens. Okay. So this is to place the needle. You will also get some amount of CSF. Not always, but you may get CSF as well. So once the needle is gone here, you can appreciate CSF coming out. And once you have confirmed, give test stimulation and then give the dose. So here is my machine. It's been set at 70 degrees centigrade. So this is the setting, 70 degrees centigrade on the right with 60 seconds, and this I have achieved. So this on the left side I have achieved. And impedance is very important. When the electrode goes in, if the impedance is between 300 to 500, that means you are in the Gesserian ganglion. It will be very high if you're touching the bone or if it is just in the CSF. It will not be 300 to 500. And then this is the elapsed time that it provides. Again, if you look here, I have continuous lesioning, I have stimulation, this is the impedance and pulse. I rarely used pulsed. So after the procedure, antibiotics for a day, carbamazepine, I gradually withdraw and then discharge after. Now I don't discharge after 4 hours. I still keep for 6 to 8 hours minimum, just for safety. And these are the set of complications that you can suffer from. Well, complication avoidance, early detection of the trajectory is very important. So initially hard palate will help you, and then provides the estimation of the trajectory in early phase. Later, the sella and the clivus is a good landmark. And lateral fluoroscopy is important to prevent complications, secondary to misplaced needle. So you cannot go beyond the clival line. The maximum you can go is 5 millimeters beyond the clavicle line. So I won't say more than 90%, but yes, up to 90% initial relief with RF rhizolysis. 15 to 20% recurrence at 12 months, and long-term results of MVD are better than RF. I won't go into extracranial complications. Thank you.
Thank you, Ashish. I think it was an excellent talk. And we'll have a demo during the cadaveric demonstration. So, Ramesh, well, I think we'll take the questions later.
Yeah, sure.
Ramesh is here. So we have two more talks. I think we're running a little late. We have two more talks. One is on ganglion impar block, followed by ultrasound guided block, especially for erector spinae block and stellate ganglion block. So these are the talks which are left. And hopefully we should finish these talks by 11:30. So at 11:30 we'll have the master demonstration on the table, cadaveric table. So you all will be sitting here. Dr. Dureja and Dr. Ashish Tandon will show you the various blocks which we talked about: trigeminal block, the transforaminal block, and also the facet and root blocks. Also, we'll also show you the stellate ganglion block if the cadaver is it is visible in the cadaver. And subsequently, you will be obviously the two groups. I think everybody has got their names. In case of any confusion, you can get back to me. So the group in the cadaver will go down at that time. Only those in those group please go. Nobody else goes. Rest here in the ultrasound group will be here, and then we swap after lunch. So now I invite Dr. Ramesh to give his talk.
Very good morning. After all the previous talks have been covered from cervical to lumbar, we'll be going to the tail end. So that is, I'll be talking on ganglion impar. Ganglion impar, also known as sacrococcygeal ganglion or ganglion of Walther. This is basically a sympathetic ganglion which is located in front of the coccyx, and this is basically a single cervical, like we have bilateral sympathetic chains. So both of them join at the tail of the tailbone. So that actually is a single ganglion. That's why impar, it means a single ganglion, which is not married. So this is the location. Usually it is located at the sacrococcygeal junction. And Plancarte they are the first people who actually did this block and described. So anatomy wise, if you see in the caudal block already we had discussed regarding, it's not working. So you have the sacral and coccygeal cornua here, so which are and this is the sacral hiatus. So this is the dorsal surface, which just for the caudal block, which we'll be doing, and the ganglion impar is located on the ventral surface at the junction of the sacrum and the clivus. The anatomy wise, it is basically a discrete ganglion, which probably difficult to see anatomically, but it is located based on various studies. It has been shown that it is of various sizes and shapes. It can be differing with different patients, and it receives fibers from basically it receives fibers, sympathetic fibers, and also pain fibers involving the perineum and all the pelvic structures. So any pain related to the perineum or pelvic region pains, you can use this block, which is very useful. And as neurosurgeons, for us, coccydynia is one where you have this coccygeal pain, and most of our patients who come to the trauma emergencies, they can have this coccygeal fractures, and then they can have this pain. So that is a area which we are interested in, that to give them this block, and it works very well for this post-traumatic coccydynia. Location wise, it has been variously described, but most common and consistent location is at this point. Sorry. So this is at the C1 C2 junction. So majority of it is located at the coccygeal 1 and 2 junction, and maybe with the various this thing, it can be there at the sacrococcygeal junction also. These are the various indications. You can take it for males, it's different, and females, it's different. But overall, it is basically involving all the pelvic structures, any visceral pain, or any pain like burning pain, which are usually autonomic in nature. We can use this block. So technique wise, the first technique which was described by Plancarte and colleagues was that they used this bent needle technique. So it was a single bend, and they used to use it. I'll come to that. Yeah. So you can see in this figure, the Plancarte's technique used a single bend, and then they use pierce this anococcygeal ligament, and then it goes inside. This technique actually is not done now more frequently because there are some problems, because this has to be curved along this, and then because of the bent tip, the surgeon places the non-dominant for a digital rectal examination, so that he can have a feel of the needle, which is uncomfortable for the patient also, and this is usually done in the lateral position. So that's the reason, and there is a very high chance that it can injure the rectum and then contaminate also, and then the physician can himself get injured with the needle. So this is then came the, and other thing is that the stylet, when you try to remove in the bent needle, it is a bit difficult when it goes in. So these are the problems associated with it, because it was described in 1980. So that technique is there, but they started using this curved needle, smooth curve, and then again the reason being it goes there along the sacrum, and then you can deposit the drug or whatever you want to put it. So now these days, these are the very short trajectories and straight trajectories. It's easy to use. So that you can use this is a Wem's technique who described this sacrococcygeal disc. There is a small disc, rudimentary although, but it is soft, and you can actually pierce through it. Through fluoroscopic guidance, you can just place the straight needle there. And the location wise, it is a very, I shown you that it has different shapes and sizes, so it can actually vary in length. So usually it is seen in this region, so you can put it through C1, C2 or below. And there are other, like sometimes the disc may be calcified. So they have been described the needle in needle technique. You can see on the other side, where you take a thicker needle and you dock it, because sometimes because of the calcification, the small needle can break inside also. So you dock it, and then you take a smaller needle inside and then give the block. So it's basically retroperitoneal, and but behind the rectum, in front of the sacrum. So various techniques have been done, like using a paramedian approach or a direct approach. You can. Sometimes there will be some calcification, sir. The disc might not be that prevalent. Yeah, it goes straight in the midline through the space, and then you dock it there. Then you use the small needle which goes inside. So this is how it looks like on radiography. So this is an inverted comma sign, they call it. You inject a dye, and you can see various X-ray images there. It goes along the sacral curvature. Complications do happen, and it can be vascular complications. The most important ones are like the incontinence which can happen, bladder and bowel incontinence, and sexual dysfunction, which might be, but they are not that common. Obviously, the hollow viscous injury can happen if you pierce more inside. So, because this is a surgical congress, I felt that there was a case which was referred from Dr. Deepak Agarwal's OPD to me, saying that you give some block. The patient already had undergone this was a post-traumatic coccygeal fracture, and he already had a block outside. Probably it was a ganglion impar block. I didn't have any details. So in this patient, we thought, because he was not able to sit, because once the coccygeal pain is there, he's always lying down prone. So that was his presentation. So we thought we'll do because coccygeectomy in this patient, because post-traumatic coccydynia, it's better to surgery and then remove the coccyx. So in this patient, we did so we have all been seeing this. So sorry, just go back a bit. If you see, there is a fracture of the coccyx. You can see the fracture line, and that was the reason for his pain. Sorry. Sir, he was in very much severe pain and he already failed a block. So we thought we could have tried, but we thought, because we could see on the X-ray and CT also. I don't have the CT image here. There was a fracture which was bent actually inside. So we thought we can remove it, and he will be pain free. And he was very desperate to get it removed because he was having severe pain. Sir. Why it is not playing? Yeah. So we did coccygeectomy in this patient. You can see the positioning. You should open up by putting straps so that the lateral cleft is open. And then we took a paramedian incision. We didn't take a midline because midline is there. The infection rate, the only problem with this surgery is infection. Up to 40% infection rate is there. So this paramedian incision you take, and then it's just a subcutaneous bone. You can actually feel the bone just beneath the skin. That is a periosteum of the sacrococcygeal junction. So paramedian incision, they have shown that you can see it is mobile actually, it's fractured. You open up the periosteum, and then today's procedures are all for neurosurgeons, but we don't see blood, and that's the reason at least we can see some blood during the surgery. So that's its mobile segment, which is fractured segment of the coccyx. The most important thing is you have to be along the periosteum, because if you go more inside, you might go inside the retroperitoneal space and then injure the. This is the disc space actually, which we could cut it. This is the sacrococcygeal junction, and we could remove it in toto. So following removal, the patient was completely pain free, and then he is happy. So for post-traumatic coccydynia, you can give blocks, but the recommended approach, because they have very good result following removal of the coccyx. So this is one of the approaches we actually, as surgeons, we can do it. So that is the reason I put this. So, and then we this is the length of the coccyx which we remove. The fracture segment. So coccygeectomy, just removing the fracture segment may not be enough, because there is a high risk of failure. That's what literature says. And then they do a complete coccygeectomy. So that's the reason we took the fracture segment as well as the C1 segment, which was not fractured. Vancomycin, sir. The infection rate is quite high because it is in that area, and we close the periosteum so that just to avoid infection. So especially for pelvic pains and coccydynia, you can use this ganglion impar block, and it is a very useful technique. You use the straight needle technique and then go inside under fluoroscopic guidance. It can be done safely. We'll be showing anyways. You can do it on the cadavers. Thank you. I will now, we'll have a lecture on ultrasound guided stellate ganglion block, and followed by erector spinae plane block. I will call upon Dr. Vineet.
कौन सा है सर बेसिक पहले कौन था भाई देखिए मिनी माइक वाला नहीं दूसरे के उसी में ऐड किया होगा उसी में ऐड किया होगा तो फिर वही तो था
So, good morning. I'm Dr. Vineet Chandran. I'm the Assistant Professor in Department of Emergency Medicine in this institute. So, first of all, I'd like to thank the organizers for actually inviting us to this conference, neurosurgery conference, which is actually not our area of domain. So, thank you, Deepak sir and others. And also, I'd like to thank my mentor, my teacher, Dr. Sanjeev Boy. He is like the last word, great innovator and a great epitome of ultrasound, point of care ultrasound in emergency medicine in India and abroad. So, since we'll be seeing a bit on the point of care ultrasound, I thought we'll start with a bit of a basics of point of care ultrasound. So, as you I'll be discussing in brief regarding the point of care ultrasound, the basic physics, the basic buttons and switches in the ultrasound, what do you see in an ultrasound image, and then we'll go to stellate ganglion block and the EPSP. So all of this would be very brief because we'll be having the same hands-on sessions in the stations also, both the basics and also regarding the stellate ganglion blocks. So machines would be different. There would be different buttons and switches for different kinds of machines, and the basic mechanism of any ultrasound machine would be to transmit ultrasound, which is about 20,000 hertz. The ultrasound would go and hit a target or hit an organ, then it is transmitted back. So the piezoelectrical crystals in the probe would transmit the sound. That sound will go and hit the target and it will come back. So based on how much it comes back, and based on how long, from what depth it comes back, the image is formed. So it depends on the tissue that it is going and hitting. So there are multiple types of transducers. We as emergency physician in point of care ultrasound use 3 types of different transducers. So this is a echo probe. This is a linear probe. Linear probe would be used in our station for stellate ganglion and for your EPSB block, and this is a curvilinear probe. So linear probe helps to visualize superficial structures better because it has a higher frequency. Higher frequency means it will tend to visualize the superficial structures very clearly, but it won't go deep. The sound won't travel very deep. So it would be a superficial structure. It would visualize a superficial structure. And there are multiple named movements for the probe, like sliding up and down. So in order to visualize a particular target, it might not be, if you go by landmark, there might be anatomical difference. So you might not be able to visualize at a single point. You might have to go above and below or laterally, or you might have to fan a bit. So it is like how you are seeing. Either you are seeing like this, seeing upwards, you are seeing downwards. So you'll have to fan the probe likewise. And also you might have to rotate to actually get a point or a target of interest. So basic buttons, on and off button, choosing the correct transducer. In our perspective, the transducer will be the linear probe or a high frequency probe. And a probe pointer is also very important. Probe pointer, as you would see in the ultrasound work in the hands-on session, there would be a probe pointer on the screen of the ultrasound screen, and also on the ultrasound probe. So these two should correspond. So it is always towards the right of the patient. These two should correspond. If that is not corresponding, that there is a possibility that the image will appear inverted. So there might be a confusion in that image. So this probe pointer should always be syncing with each other. So if we are looking on a craniocaudal view, the probe pointer is always towards the cranial aspect, or transverse view, it is towards the right side. And choosing the right depth, so there is a button for depth. So choosing the right depth is also very important. It is always necessary that the area of interest should be in the middle of your screen, not too shallow and not too deep, because there is a possibility that you might miss that structure. So that structure should be at an adequate depth. And there is also something called as gain. Gain is actually the brightness of the image, and that can also be corrected, or that can also be selected on the ultrasound machine. So it should be enough. If it is too dark, you might not be able to visualize, and if it is too bright, then you might mistake other structures for the structures of interest. So it should be balanced gain. So there is a button in the machine to do a auto gain, where the machine would itself select the adequate gain. But selecting the gain would come with a bit of a practice also. More you see the ultrasound image, more you will be able to identify what is the correct gain for that image. And there are multiple modes also, like B mode, M mode, and Doppler mode. I don't think we'll be requiring those things now. And there are some image artifacts. So as I had already said, it is the ultrasound wave that is going, hitting and coming back. So fluid or any fluid containing structure would always absorb all the sound ultrasound wave that is coming to it, and so it would appear anechoic, because no ultrasound wave is being reflected back, all is getting transmitted, so it will appear anechoic. But bone, air, it would reflect all the light sound waves that is coming and hitting it, so it would appear hyperechoic or white. So if it is absorbing, it would appear anechoic, and hyperechoic would be white. And other structures like kidney, liver, they would have different levels of absorption and reflection. So the machine can detect actually around 256 shades of gray. 256 shades of gray would be detected by the machine. So it would appear at different levels of hypoechoic. It would be hypoechoic at different levels. So this hypoechoic grayishness is different from this grayishness, so it would appear, and there is fluid in here, so that is why this is appearing anechoic. So we will identify structures based on its echogenicity. If it is, so when you are doing a stellate ganglion block, or when you are doing an EPSB, the identification would be based on the echogenicity. So EPSB, you are identifying a bone, you are identifying the transverse process, so it would appear hyperechoic, white. Stellate ganglion, you are targeting the carotids. Carotid is fluid blood, so it would appear anechoic. So that is how you would identify the structures. And to say a structure is a hyperechoic structure like a bone, there will be something like a posterior acoustic shadow, because it is reflecting all the sound upwards. The area posterior to it would appear dark. So that is an artifact called as a posterior acoustic shadow that is seen typically in hyperechoic structures. Okay, and like I said, urinary bladder, it will absorb all the, or it will let through all the ultrasound wave coming through it. So the posterior of it would appear hyperechoic, or posterior of it would appear more bright. That is called a posterior acoustic enhancement. So this is, so, and you can also document your findings. You can document your the observations that you're seeing in ultrasound with, there are option to click or save a image, or option to save it as video. So that is a basic regarding the ultrasound machine and the buttons related to ultrasound and the physics related to ultrasound. Now, coming to stellate ganglion block and erector spinae block, the indication that we use in emergency medicine for stellate ganglion block, actually there are only case reports that suggest, and we also have practiced a number of cases where stellate ganglion block actually helps in patients who comes in arrest, cardiac arrest, and who is not having a who is having a shockable cardiac rhythm but is not getting reverted with multiple shocks. So patients, so that is a term called as an electrical storm, where the patient is not getting relieved, or patient is not getting reverted with multiple shocks. In that case, there are case reports and saying that stellate ganglion block can actually help. So that is how we started using stellate ganglion block or practicing stellate ganglion block. But for your community, I think it would be a different indication. It will be like for complex regional pain syndromes, peripheral vascular disease, post-herpetic neuralgia, chronic post-surgical pain, and phantom limb. So I was unaware of these indications until sir had called us for this conference or for this workshop. So that is when I got to know that the stellate ganglion block can be used for these things also. So a bit about the anatomy. It is formed by the inferior cervical and first thoracic ganglia, and it is the sympathetic chain actually, and it is adjacent to the C7 vertebrae. So as I have already said, we will be using a linear probe, and it would be kept at the neck, just adjacent to your Adam's apple, just below your, just at lateral to your cricoid. And in that area, you would see this is the trachea, cricoid and trachea would be visualized here. This is the thyroid gland, and you will see the jugular vein and the carotid artery. So just beneath the carotid artery, you will see a hyperechoic structure, a whitish structure. So that is the stellate ganglion. So anyway, we will visualize the same in the live model here. So I think this will be more clearer there, and you will see a hyperechoic structure. So the structure that you see here is the esophagus, a muscular structure, and posterior to it you will see the transverse process of C7, a hyperechoic structure, transverse process of C7. So all this would be again shown in the model. So I think it would be more clearer there. So you just need a ultrasound machine with a curvilinear probe. You need to drape the area, do a cleaning of the area, and either bupivacaine or lignocaine can be used. And it's just a needle and a syringe. You don't require, it's a superficial structure, it's just a needle and syringe, and it is how you needle to that area, because you have vital structures above, carotid and jugular above. So how you needle to that area is the only important thing. So this is how we would approach to the, so we would be approaching from here, from laterally to medially to the structure, and we will be depositing the lignocaine jelly in that area posterior to the carotid. So if you get a successful stellate ganglion block, that would have signs like Horner syndrome, nasal congestion. So obviously we don't see this in a cardiac arrest, but theoretically if you successfully block a stellate ganglion, you will have Horner syndrome, nasal congestion, venodilatation of the ipsilateral hand and forearm, and increase in temperature because of loss of that sympathetic activity. So there can be complications like ipsilateral numbness, hoarseness of voice. That you might prick the artery causing hematomas, vascular injury, or even if you go a bit deeper, you might cause a pneumothorax. And the one of the most important complication to be thought of is last, local anesthetic toxicity, systemic toxicity. So always the dose calculation should be thought of, and that only the required dose should be given. The maximum dose should also always be thought of before the drug is prepared and drug is administered. So that is regarding the stellate ganglion. Now regarding erector spinae block. Erector spinae block is something we use regularly in emergency for rib fractures, but we also have tend to use it a bit for medical causes also. There we have used the erector spinae block for patients coming with acute severe renal colic. Once or twice has been used. Patient with acute renal colic, erector spinae had was found to be useful. Patient coming with pancreatitis, severe pancreatitis, retroperitoneal pain, patient having epigastric pain radiating to back, bilateral erector spinae block was given and was found to be helpful. And also had used once for a patient with duodenal ulcer, severe pain, not perforated, but a history of duodenal ulcer, severe pain, which was also given, and the patient had some relief. So mostly for trauma, mostly for rib fractures is what we use here. So as per your indications, it might be acute or chronic pain syndromes, definitely for rib fractures, and also for postoperative pain management. So the erector spinae muscle group is formed by the iliocostalis longissimus and the spinalis muscle. So what we are trying to give is at this level, at the transverse process level, where the drug would be given, and it would, we hope it to spread superiorly, inferiorly, and always also transversely. So this would be the position of the patient sitting up, and it is always important to have this ergonomics right. The patient, the person who is performing, and the ultrasound all should be in line. So do the positioning of it is wrong, then it would be difficult for you to visualize the thing, to visualize give the drug. So that probe positioning and the positioning of the ultrasound machine is also very important. So this is how we would be approaching. This is the transverse process. So this also we'll visualize, we'll see in the hands-on workshop, the transverse process, the skin and subcutaneous tissue. This is the erector spinae muscle group, and we'll be approaching from laterally to medially, hitting the transverse process and depositing the drug between the transverse process and the erector spinae muscle group. So the requirements are the same. You need an ultrasound machine with a linear probe, and then depending on your indication, you can use lignocaine or a bupivacaine. So the dose is 20 to 25 ml of local anesthetic. Initially a bit of a hydrodissection. You initially inject saline, 5 ml or 10 ml saline, do a bit of hydrodissection, and then deposit the drug there. So the plane is already dissected, and the drug will easily suffuse to the other areas. Dexamethasone and sodium bicarbonate are also added to increase the duration of the drug effects. So there are complications are very rare, but possibility of a pneumothorax and injection site infection is definitely there. So ultrasound, once you go to the I don't know how many of you might be using ultrasound, but when you go, once you go to the workshop, the hands-on session, you would find that ultrasound is not that very difficult. It's all gray and black, but it's not that difficult once you get the hands of it, once you get to know the how to needle it and things like that. It's not that very difficult. Okay, so thank you for listening to me.
Sir, you can also, I think, Dr. Ashish, connect to the cadaver lab. Connected?
Sir, can you hear me?
Yeah, Dr. Mohini?
Yes, sir.
Yeah, hi.
Hello,
So, Dr. Mohini is a senior resident in the Department of Emergency Medicine. She will be showing us ultrasound guided stellate ganglion block, actually localization. So the screen is visible a bit dark. Dr. Mohini, you can actually start
Okay, hello everybody, I'm Dr. Mohini. So today we are going to see how we do a stellate ganglion block. So for the block, we need an ultrasound machine with a linear probe. This is the linear probe. So we'll also need a lignocaine for local injection and also for the injection at the stellate ganglion. So using a linear probe, this is my marker, and I'll keep it on the neck at the level of C6 and then fan it from medial to lateral. So as I go from medial to lateral, here you can see this is a rounded structure with an anechoic inside. This is a artery, the carotid artery, and then lateral to it you can see a collapsed structure which is an internal jugular vein. So and if I fan it a bit, I'll show you the C6 tubercle as well. Okay, so now can you see a white hyperechoic structure below which there is a posterior acoustic shadow? This is the bone. So this is the transverse process of C6.
Can the
So
laptop
this is where
can the
we
laptop screen be
inject the
made a bit straighter because it's not?
lignocaine or the bupivacaine, whatever analgesics we are using. So now we'll have to locate where is the cervical ganglion. So basically it's formed by the inferior cervical and the T1 ganglion. So it will be just below the carotid. So here you can see a hyperechoic
is the
structure
carotid.
just below the carotid here.
And this region she's talking
So
about.
that is the ganglion that we are targeting, the stellate ganglion. Hello? Hello?
Hello, yeah, Dr. Mohini.
Okay, sir.
Yeah, you're audible.
Okay.
So you can show us the C6 Chashaknis tubercle.
Yes, sir.
Again.
So this is the Chassignis tubercle. This is the hyperechoic structure above and a posterior acoustic shadow below it. It shows that there is a bony structure here. This is the Chassignis tubercle, the C6 tubercle.
This one, yeah.
Yes.
Okay.
So here is the internal jugular vein. This is the rounded structure, the carotid artery, below which there is an hyperechoic structure, which is the stellate ganglion. So this is the plane. Actually, in this patient, in a normal patient, the IJV is not this collapsed. So it will be just here, rounded structure. So the plane will be this to inject the lignocaine or the bupivacaine, whatever we are using. Right now it will be a bit difficult to go because I'll have to cross this IJV. Otherwise, it's never to cross this IJV. We'll go on an in-plane approach, and through this, we'll come like this and inject the lignocaine or the bupivacaine here, just periphery to the ganglion. So,
yeah, so the injection takes place at below C6, C7,
Yes,
so that it is
so
spreads.
using
That's
an
the key.
in-plane technique,
Yeah.
I'm trying to inject this.
So for us in neurosurgery, this is good for vasospasm. We can do this as a bedside procedure using the ultrasound.
So I'm there. I'll just show the dissection that it does. Okay. Can you see the dissection in this?
Yeah.
Just there. That's where we need to inject the analgesic agent. Thank you.
Keep the needle there, Dr. Mohini. Can you just keep the probe there again?
Yes, sir.
Yeah, there is a lifting up of that plane.
The
So it's-
structure beneath and above, it lifts, sir.
Yeah, it's
Due to the
it's basically the prevertebral above.
Yes, sir.
Yeah. Thank you,
Thank you,
Dr.
sir.
Mohini. So next we can move the camera to the cadaver for demonstration of the blocks by Professor Doreja. Doc, yeah. आगे, आगे. So, Professor Dureja, we are able to see the X-ray images. Dr. Rajesh?
Sir,
Put the camera view and PIP. माइक है वहां पे किसी के पास? डॉक्टर राजेश?
हाँ दीपक
Yes, sir.
या कैमरा का है ठीक है so yeah we are here now ये प्रोन में है सारी प्रोन में सीधी भी है या प्रोन ही है सारी
प्रोन है आई थिंक सर.
ठीक है ठीक हमें एपी चाहिए ठीक है एपी ऑब्लिक लेटरल बताता रहूँगा कौन से लेवल पे
एक्सरे पीआईपी में दे दो ना.
फुट पैडल है फुट पैडल मुझे दे दो उल्टा करो इमेज को ये हटा दो मेरे सामने से
हाँ.
अच्छा ये वहाँ जा रहा है नहीं नहीं ठीक है ये कैमरा है
बड़ा करो
उल्टा करो
पीआईपी को बड़ा करो
उल्टा हाँ घुमा दो ठीक है चलो अब आप थोड़ा सा इसको सेंट्रल लाइन में लाओ वापस घुमाओ बस थोड़ा सा की तरफ लेके जाओ सेंट्रल लाइन में आए नहीं यार अरे बीच में आना चाहिए ना तुम वहीं पे रहो तुम समझे नहीं इसको बीच में लाओ स्पाइन को यूँ ले जाओ बस छोड़ दो बस छोड़ दो ठीक है ठीक अभी नहीं डाई पे चाहिए होगा हाँ डाई है ना डाई भी है ना डाई
सर वी नॉट
ठीक है सर ठीक है हाँ ठीक है so we'll start with the basic AP view of the spine
राइट
as,
सर.
as we had discussed in the morning and फिर से आप थोड़ा अपनी तरफ ले जा इसको बीच में ला स्पाइन को उधर भी देखते रहना स्क्रीन में भी देखते रहो अरे बस यार बस
स्लोली मूव किया करो
बस इंच बाय इंच so this is the AP view and you can see that we are aligning the spinous process in line. This is the spinous process, this is the spinous process, this is the spinous process and various structures which we highlighted in the morning. This is the interlaminar space. So beautiful interlaminar space. अगर आपको you have to go through for the epidural, you will have to go through this interlaminar space right in the middle, and then मैंने अभी दिखा रहा हूँ. So this is the interlaminar space. Then you can see the foramen also. But to get a better view, and this is the pedicle, this is the transverse process.
Right.
This is the inferior end plate, this is the superior end plate, which we have removed the parallax and they are in line. So this is ideal appearance of a AP view. So AP view में the only thing which you can do is a interlaminar epidural. You will go through this and then go by the loss of resistance technique. Epidural needle नहीं epidural. So this is like an epidural needle wherein I will go syringe है ना. Yeah. So I will go like this, and then मैं वैसे बता रहा हूँ कोई बात. So LOR syringe यहाँ पे कैमरा है, दिखा रहे हैं ना?
हाँ दिख रहा है सर.
दिख रहा है. So I will keep going. अब इसमें तो you can't have a loss of resistance. अभी हम तो कर रहे हैं, देख लेते हैं.
इसमें भी आता है.
आ जाता है, चलो. Yeah. Now you see immediately when I pierce this, there is a loss of resistance. It's not bouncing back. You don't get a fair idea, but yes. Yeah. So this is how you do it. Epidural, and then you see the spread of the dye, which I said most often goes linearly, but if you give larger volume, sometimes it may go into the lateral recess also, the lateral canal. But generally, for the central canal, as we were discussing in lumbar canal stenosis, we can do this and give relief to the patient.
Right.
Now, if in order to do, please, Dr. Deepak, if anybody has question, they can keep
Yes.
asking her. Now, this is the AP view and the advantages of AP view and what you can do on a AP view. It's all there. You in order to do the transforaminal block, now you have to turn into oblique. Estrella.
To see for the Scotty dog.
Yeah. ठीक है, एक मिनट, इतना नहीं यार, इतना नहीं भाई, इतना नहीं, बस. So now you see the classical Scotty dog which we were mentioning. तो अगेन थोड़ा सा पैरलेक्स है, तो थोड़ा सा ऐसे ले जाइए ऊपर की तरफ, कैफ्लेड हेड की तरफ. हाँ,
Slowly.
बस. That's it. So we remove the parallax of the inferior end plate and superior end plate. So if I have to do a discal procedure, I'll go from here. So if I have to do any discal procedures, I will go from here. We as pain physician do some like ozone discectomy and all, or discography, provocative discography. Then I will go from here. Yes, this is like discal procedure. If I have to do a discography, I will enter from here, and now I'm in the disc. So right now I'll make it. This is just to show you a discal procedure, provocative discography, or if you want to put ozone, or if you want to do any of these hydrodissections which were popular earlier, or striker decompression, you can use this technique.
So this is the same infraneural approach, sir?
Yeah, this is the same infraneural approach, but now I am entering the disc. AP view.
Right.
Yeah. So AP view will show you, yes, your needle is going in the disc, and in order to confirm whether you are in the nucleus pulposus or not, then you have to see the lateral view. Yeah, fine. So now lateral, पूरा lateral, dead lateral.
इसको shift कर दो इस image को to the right side.
इसको वहाँ पे सेव कर दो, इस इमेज को वहाँ सेव कर दो. ठीक है. Now lateral view, थोड़ा सा नीचे जाना, हल्का सा पिक्चर. ठीक है, पिक्चर थोड़ा सा इसको ब्राइट करना, केवीए बढ़ाना, केवी बढ़ाओ, दिखाओ, shoot. Yeah, so you can see we are in the disc and we are in the middle of the disc, so roughly around nucleus pulposus in the middle, you can see this. Right, this is layout AP. नहीं, sorry, oblique ही रहने दो. So we are again into the oblique. KVA कम करो, KVA कम कर दो. KVA कम, थोड़ा सा आगे लाओ. Yeah. So we are back to the position. अभी थोड़ा सा ऐसे हेड की तरफ लेके जाना. हेड की तरफ. हेड. ये सियाम को ऐसे हेड की तरफ. ना. रोटेट ऑब्लिक. हाँ. बस. नीचे लाओ. नीचे लेके आइए. जब मैं ऐसे करूँ तो ऐसे है. ऊपर करूँगा तो ऐसे बोलूँ. So now we are. इसको नहीं थोड़ा सा वापस लाइए. Again the parallax has to be removed. Yes, correct. So now for the transphenomenal approach, as I said, this is the safe triangle. If you have to use the safe triangle or Cameron triangle, this is the safe triangle just below the pedicle. Right? Needle. Find the needle. So we have bent the needle a little bit. This is to show you that we, sorry. This line has to be straight. The line has to be straight, absolutely straight. So the needle has been bent. We don't have a spinal needle. Do we have a spinal needle? So I will just
full screen kar do jara
show you,
camera.
Show you that how we bend the needle. So this is how we bend the needle.
Okay, sir.
Right? And then yeah. So the needle position has to be in the line of the C-arm. So at the angle where you are getting this picture, you have to go in that angle only.
Right.
So I am just below the pedicle. I am hitting the pedicle now. Hitting the pedicle, and as I said, just slide past the pedicle. I am now sliding past the pedicle. This is the safe triangle. Sliding past the pedicle. I may not go and hit the wall. I am hitting the wall. Now I am hitting the wall. So I am sliding past, and this is the safe triangle, and this is the place where you can safely, you will not injure the nerve, and you can safely give your local anesthetic. Now again lateral, just to see in the hitting the posterior wall of the foramen.
Right, sir. Right.
Lateral. So again, as I mentioned, in two views you have to see. In one view you are seeing, but you have to confirm it in the lateral view. I may be just hitting the pedicle only. I may not be in the foramen, so that has to be confirmed.
Correct.
Yes.
Sir, can you show us the position on the skin from where to enter?
Skin entry point. People
Yeah, this is the entry point. Entry points are all based on your fluoroanatomy. Entry points are no, I mean like past 2 centimeters here, 3 centimeters here. No. They have to be in what you see on the fluoro screen. That is how you have to. So this entry is like in line with the C-arm. C-arm was oblique, so I am in line with the C-arm. It was just sort of a tunnel vision because the needle was bent, so you could see it. And now in the lateral view, you can see I am in the foramen. So I am hitting the wall of the foramen. Yes. I may just maybe withdraw a little bit. Yeah, that's it. You can see the foramen there.
Yes.
This is the foramen, and I am in the superior part of the foramen. Can you see that?
Right, sir.
So this is definitely, as a beginner or otherwise also, you should confirm it in two views. One, that you gave it in oblique view. Second, that you confirmed it in the lateral view. And perhaps I will put my dye in this view only to see the spread of the dye, and then confirm it again in the oblique view to see if the dye is spreading along the nerve root or not. Epidural spread is not very important for me. That spread along the nerve is more important for me.
Okay, sir.
ठीक है? हाँ.
So you have shown us the epidural block. You have shown us the transforaminal.
Yeah. Now we go to the facet and the medial branch.
Right, sir.
And the disc also I have shown you.
Yes, sir. Disc also.
फिर से KV को बढ़ा दो. हाँ. Now, no. This is all fluoroanatomy. There is no distance 2-3 centimeters. So whatever I am seeing, KV बढ़ाओ भाई. Yeah. So now I am seeing these facet joint. Supposing I want to take this facet joint, the parallax is removed. So this is an interfacetal joint injection, right? This is not a median branch block. This is a interfacetal joint injection. Use the thinnest needle. So maybe I'll use a 23 gauge needle. Yeah. So I'm now progressing. That's the superior articular
You can see
surface.
this two.
And now because it's a needle is bent, so you can see that I'm into the foramen now. I'm into the facet joint.
Right.
I'm into the facet joint. Maybe
That now you are in.
now I'm in. Now I'm
Because
in.
this is one line and
Yeah, this is
another.
one line and I'm in.
Yes, now you.
And you can put a dye and see, but again very little amount of dye. This is a very small joint which has a capacity of 0.3, 0.4 ml. It's an open joint. It has a capsule, so we don't like to puncture the capsule again and again because it can produce instability. And dye also, if you put lot of dye, lot of drug, it can sort of damage the capsule of the joint. So a 0.1 ml of dye will spread and 0.2 ml of drug would be okay. So don't exceed more than 0.4 ml of the injected, including the dye. If you're very confident, like sometimes when I put a needle, it's an inflamed joint, the fluid comes out. I have withdrawn up to 2.5 ml of fluid from the facet joint. So decompressing the facet joint itself produces very good relief in pain. So therein we don't put dye, we just put that drug. So that's it. That's a facet joint injection, which we normally do in lumbar canal stenosis with severe facet arthropathy, where there is a lot of inflammation, lot of axial pain, and which is contributed by this. But yes, inflamed facet pressing the nerve, just behind the facet joint is the nerve root, so it can also produce radiculopathy, just facet joint, and there may be degenerated disc, but patient having radiculopathy because of hypertrophy of the facet. So,
Correct, sir.
So this helps in decompressing the facet joint and relieving your pain. Yes. No, bending is convenient and comfortable because you see the lower part and you can negotiate the lower part into the joint. Similarly, like in transforaminal also, you hit the part and then just rotate the needle and you will go past the pedicle into the safe triangle. Now coming to the थोड़ा सा इधर और कम करना oblique, नहीं ये oblique को कम करना. Now coming to the medial branch block. ठीक है. So now this is the facet joint, and as I was telling you, from the above root, there is a branch which comes and supplies at the eye of the spotty dog. So this is the eye. So there is a groove there. If you see the bone model or if you see the vertebra, there is a groove there. So our target is that groove from where the nerve is traversing. So that nerve is lying parallel to the bone.
Okay.
Yeah. Yes. So this is a groove. You can't see a Scotty dog here, but you can see this groove. So from this root, from this lumbar root, a branch is coming over here. So my target would be this particular groove. Yeah. So this branch is coming here, and my target will be here. So this, and the nerve is lying absolutely in touch with the vertebra. It is not projecting out. It's like lying parallel to the vertebra. So my needle again has to be as close to the nerve. If I go like this, I will be hitting very small portion. So I have to go parallel to the nerve. So I have to be in maximum touch. So bending needle and then positioning the needle in such a way that it goes like this.
Right.
Right? So you can come from below and position your needle here, rather than going over there straight away. Straight if you go, of course in radio frequency it might work or a diagnostic block also because it produces a lesion of 5 to 10 mm. But if you're close to the nerve, you will be able to block the maximum nerve, and that will be very helpful. So you can go from below and then lie parallel to the nerve rather than going AP view and then just hitting a small portion of the nerve. So you should not miss it. Local anesthetic is okay if you go straight like this, but if you want to do RF, you have to go from below and lie parallel to this, because you want a maximum area of the nerve to be. I will just show you. Yeah, for a diagnostic block, I'll show you. So we are at the facet. Yeah. So for a diagnostic block, maybe I can go like this, because so I'm hitting that groove. No, I'm not yet hitting. No, it's moving away. Yeah. So it has to be a tunnel view, which I'm not getting now. Yeah. So more of a tunnel view. Yes. So that's the area which I'm touching, and if I stimulate, I will get some stimulation here. This one. So this is the place where I will do a diagnostic medial branch block. So 0.2 ml, and it is lying at the groove. So if I just slip past, it will go into the root. So I have to give only 0.2 ml, 0.3 ml of local anesthetic.
Right.
Because local anesthetic is a volume, it will block it. No. Yeah, no, that is not the eye. So earlier, it was said that this is the eye, but this is the eye. But the nerve does not reach there. Nerve starts from the groove and then goes past the groove into the facet joint. This is the facet joint. It comes like this. It doesn't come here. Yeah, basically at the groove. No, little above. Right? But in case I have to do a RF, then I'll go like this, oblique, and try to be as close to this in this manner.
So, sir, what next? What are you going to show?
Just 1 second, I'll just finish this. So then I'll be going like this, so that I am able to get the maximum area of the nerve, and then do. And I will do at 2 levels, one above and one below. So this also and this also. So for RF, no, this will be different. You have to go a little above. No, I'll have to go from above and then reach it. So this is RF, and this is medial branch block, facet block, interdiscal, then the transforaminal. Anything else? The caudal, shall we continue the caudal? Caudal. Lateral कर दो. Lateral देखा आ जाएगा. नीचे लो. यहाँ पे लो. ठीक है, बहुत बढ़िया. थोड़ा ऊपर ले जाओ. सियाम को ऊपर करो. नहीं सर. सियाम ऊपर करो. हाइट अप. ओ, अच्छा. नहीं हो जाए. केवी कम करो. थोड़ा सा नीचे ले जाओ, हल्का सा. नहीं. दिख रहा है कहीं? दिखा? थोड़ा सा हल्का सा ऊपर करना, हल्का सा. बस. हाँ तो नहीं. हाँ ये रहा, ये आपका. हाँ ठीक, ये रहा. पता नहीं, needle डाल के देख लेते हैं.
What are we seeing, sir?
We were trying to see whether we can do a caudal epidural. I don't know. छोड़ दे ना. थोड़ा सा ऊपर करना, हल्का सा. हाँ ये. आप ऊपर उठाओ, सियाम को ऊपर उठाओ. हाँ पर वो. नहीं होगा. हाँ ये आ जाए. नहीं आ रहा ना. थोड़ा सा केवी कम करो. होता है मुश्किल, कल भी नहीं आ रहा. और किसी पे. हाँ जी, थोड़ा सा तो आया.
Dr. Ramesh, do we have the other II with the patient supine?
Yeah, we have entered. So this is into the caudal space, and थोड़ा सा ऊपर जाएंगे तो आप सारा कुछ देख पाएंगे, L5, S1 वगैरह. So this is in the caudal space, and we then put a dye and see the spread like we showed you on the picture there. ठीक है जी. Sure.
It is not clear on the screen, sir.
Sure. Now ऊपर ले जाओ cervical spine में. We'll see if we can see a bit of cervical spine.
Right, sir. Dr. Ramesh, get the patient ready supine for supine procedure
AP कर दो, AP.
with the II.
AP. Getting ready, sir. ये सीधा कर ना. हाँ. और अपनी तरफ ले जाओ. नहीं, इसको रख दो, इसको लॉक कर दो. अब अपनी तरफ मशीन ले जाओ. ठीक है, अब तुम जरा केवी बढ़ा दो, केवी कम कर दो. या थोड़ा सा, अब थोड़ा सा मेरी तरफ लाओ. नहीं, इसको मिड लाइन में ले आओ. थोड़ा और करो. ठीक है, बस लॉक कर दो. So for cervical epidural, as we were discussing, this is the C6, C7. That's the place from where we go in. And do an interlaminar. And for the transforaminal, this is the transverse process. So in lateral position, we put the needle here. मुश्किल ही होगा ना. So this is how I'll go into the foramen of the like we mentioned about selective nerve root block in the cervical region, and for epidural we'll go there. And so दोबारा से ऑन करो मशीन को. मशीन 5 मिनट हो गए, दोबारा ऑन करो. ऑन करो. And in order to block the facet joint, lateral कर सकते हो. देखो lateral. या बस. ठीक है, बहुत बढ़िया. So this is the facet joint. As you can see, this is the facet joint. And on the articular pillar, if I go, this is the place for the. Dr. Deepak, can you see that?
Yes, sir. Yes, sir.
So that's the place for medial branch block, and that's the facet joint, and this is the place where I will do my RF as well as medial branch block.
Right, sir.
And then of course the foramen and other things are visible here. So this is the body of the cervical vertebra. Very nicely you can see the articular pillar,
Yes.
the facet joint.
So you will be doing the RF in the articular pillar.
Articular pillar.
Right, sir.
Even the medial branch block on that, and RF also on the articular pillar. So two articular pillars, one above, one below, of the affected facet joint. And intra-articular facet joint, you can go directly into this facet joint. This is the facet joint. Directly into
Dr.
this.
Dureja, the question is in AP view, where should the needle be?
Pardon?
In AP view, where should the needle be for this articular pillar block?
No, see, basically, articular pillar is difficult to see in the AP view.
Right.
You may see the needles, but very difficult to appreciate the articular pillar. So the best is obviously a lateral approach.
Right.
Best is a lateral approach.
So in a normal patient, the patient will be lateral.
Yeah.
When we are doing this approach.
Yeah, like you can see the hand by the side.
Right.
That's the best thing to get a view of the neck. If your hands are above, like we do in cervical epidural, then it is difficult to identify this structure in the lateral position. So if the hands by the side down below, you can have a better view of the neck and all these structures.
Correct, sir. Thank you, sir. What next?
Huh?
Trigeminal
Erector
neuralgia.
spinae, yeah. You want to see erector spinae? Apical. Erector spinae, I mean, of course, ultrasound, but under fluoroscopy also it is very easy. Yeah, I was there. So we do it under either of the things which we get, but fluoroscopy is equally okay because you see the transverse process and you read the transverse process. इधर ले आओ, इस level पे ले आओ, thoracic level पे ले आओ. बस ये तो उड़ गया यार तुम्हारा कनेक्शन, वहाँ चला गया लगता है, वहाँ चला गया. मेरे ख्याल से उधर चेंज हो गया. So basically you see the under fluoro, आप इधर रखे हो ना, so you हाँ ठीक, इसको रोटेट कर दो, उल्टा कर दो, घुमा दो, घुमा दो. घुमा दो, घुमा दो, घुमा दो, घुमा दो. शाबाश, शाबाश, वेरी नाइस, वेरी नाइस. बस बस सर थोड़ा सा, बस. So now you see this is the transverse process and
sir.
this is the transverse process. So your needle has to lie here.
Okay, sir.
No ultrasound required. I mean, of course, I have both, so wherever I want to use ultrasound, I can use. But here, yeah. So I'm putting the needle there. You don't need a very big needle; just a hypodermic needle would be good enough. So now I'm going past. So yeah, now I'm on the transverse process. So you just have to slip past between the, yeah, now I'm exactly over there where I should be. Between the transverse process and just slip past, yeah, just the erector spinae lies there. So you can even inject on the transverse process, no problem. Just slide past, but you have to be careful because the pleura and all are there. So hitting on the transverse process, I'm hitting on the transverse process, that's the rib, hitting on the transverse. So this has eliminated the use of paravertebral blocks earlier which we were giving. 2 levels, and I give 20 ml, it spreads and gives a fantastic. Even for chronic pain we are using this.
Right.
Pain. So like patients with thoracic paravertebral pain, MRIs are normal, you don't understand what is causing that pain, and you just put this and the patient gets relief. But you have to repeat it for some time. So this is right on the transverse process. So you can select the lower transverse process. This is again the transverse process. I'll select these 2-3 levels, and this is how we. Yeah, if you go at 2-3 levels and deposit, you can increase the level of. Bilateral, yeah, depends on the patient's pain. We do it more for chronic pain, but like thoracotomy and all, anesthetists are doing for pain relief also. But we do for chronic pain. Bilateral also you can do, but the volume increases. So one by one, it is better to do one at it, one in one sitting and the other in other sitting. So you don't have to use this long needle. If it's a obese patient, final. Otherwise, an hypodermic needle can also reach there. 1.5 inches needle can reach over there. So this is how you place it and deposit. Just touch the transverse process and deposit. It will spread. We have put in dyes. You can put a dye and see it's a linear spread. Wonderful.
Thank you, Dr. Dureja.
Thank you, sir.
Thank you so much.
Thank you.
Ramesh, what is next? Can we see Dr. Ashish Tandon also?
Oh, ठीक. ये सीख लेते हैं. स्टूल निकाल लेते हैं.
And I would request the people downstairs to, if you have to ask questions, to use the mic because nobody can hear here. Or you please come up.
मैं धीरे धीरे कर लेता हूँ यार, समझ तो आ गया ना ऊपर सबको. थैंक यू, थैंक यू, थैंक यू. हाँ देख के जाते हैं. नहीं नहीं कोई बात नहीं, कोई बात। गुड ना।
So
मैंने इतनी जल्दी कर दिया।
are we with
मैं
Dr.
खड़ा हो
Ashish?
जाता हूँ।
Dr. Ashish, we are there with you. माइक लगा दो.
ये मेरा माइक ले लो, ले लो, ढूंढना पड़ेगा तुम्हें।
ठीक है, मेरी तरफ लेके आइए, थोड़ा सा हल्का सा मेरी तरफ लाइए.
Dr. Ashish, we are there with you.
Yeah, hi Deepak.
Yes.
So this is the submental view. वो foramen oval clear दिखाइए और केवी थोड़ा सा बढ़ा दीजिए. हाँ, so this in here is the foramen oval. Okay, let me pull out the needle. यहाँ दिखा दीजिए. Okay, so I can't put my finger in, it's very stiff.
Okay, no problem.
Yeah, so this is the lateral canthal line. Okay,
Yes.
so you get the submental view,
Right.
and about 3 centimeters lateral to the oral incisura, and then you take your needle towards the foramen oval. ठीक है, शूट करना.
But in this view, we will not be seeing the hard palate and everything.
No, no, I'll show you. हाँ, शूट करिए. Shoot.
How do we identify the foramen oval in this view? Dr. Ashish?
हाँ, अभी शूट कर दीजिए. या क्या कह रहे हैं दीपक?
How do we identify the foramen oval in this X-ray?
Yeah, you can see the foramen oval here. एक you can see the foramen oval here.
Okay.
And lateral कर दीजिएगा. Submental.
Any landmarks for the same, Ashish?
So 3 centimeters
No,
lateral.
no, in the X-ray. Foramen oval. How do we know that this is the foramen oval? I mean, we are beginners. That's why we are asking. Because this whole thing appears to be, cystic kind of.
I'll show it to you. Don't worry. हाँ, इसको सीधा कर दीजिए. इसको सीधा कर लीजिए. हाँ, नीचे कर लीजिए. So basically you start. अभी देखिए again on lateral जब आप जा रहे हो, नहीं हाइट बढ़ा लीजिए. हाइट बढ़ा लीजिए. ओके, हाँ, इसको सेव कर दीजिए उस तरह. हो जाएगा, करिए. हाँ, अभी लैटरल शॉट ले लीजिए. थोड़ा सा मेरे तरफ आएंगे, हल्का सा नीचे. बस बस बस. हाँ, शूट कर दीजिए. हाँ, वो ठीक करिए. केवी ठीक करिए और ये फ्लिप कर दीजिए. फ्लिप कर दो इमेज को. हाँ, ठीक है, ठीक है, परफेक्ट. और केवी कम कर दीजिए. ओके, so good sella picture, good clival picture. ठीक है, the hard palate is seen. और केवी थोड़ा सा कम कर दीजिए. So see, generally you don't require to see, but what it is just in the interest to give. When you start initially, if you have the lateral palate, you have to be in the posterior 1/3 to begin with. Then you have the clival line. This is the sella. There should be no parallax. This is the petrous. So you go at the junction of the petrous with the clivus. तो वहाँ पर आपको ये entry मिलेगा. Okay.
Okay.
So this is about on the lateral. But if the best thing is to go submental view and submental and oblique, not pure AP submental nahi hai, submental, and then you tilt the C-arm towards the side of interest,
Right.
and then you see the foramen ovale here. Okay, तो वो मिल जाएगा, तो you can just go end-on types. Okay.
Into this. Okay. Understood. एक बार can you just again have the X-ray machine put in the segmental view so that
Yeah, I'll show you the submental also.
how we take the
तो ये यहाँ पर आपको दिख रहा है, जैसा मैंने आपको बताया था, lateral part of the orbit
right,
and lower part of the maxillary sinus just lateral to it.
just lateral to it. So
Yeah,
this,
so you will have that. Mostly you can see, but you spend some time in identifying. Sorry.
understood.
Okay, so any questions?
No, I think it's very nice. We just want to see the X-ray placement, the machine.
चलिए इसको AP
आशीष।
कर लो पहले.
Ashish, this is Dr. Chandra here.
Yes.
Can you again show on the AP view submental?
Yes, sir,
I
I
was
will,
not
I will.
able to catch
चलो
it properly.
AP लेके जाइए. सियाम में आ जाइए. एक मिनट, ये सियाम दिखा देंगे क्या? Okay, so sir, first we just do simple AP.
Okay.
Just pure. ये पूरा जीरो नहीं है, पहले जीरो लेके जाइए. Full zero, हाँ ये जीरो आ गया. Okay, take it towards you. ये दिखाते रहिएगा how we are manipulating this here. इसकी height बढ़ा दीजिए. Height बढ़ा दीजिए. Height बढ़ाइए. Okay. So sir, first is we are reaching pure bang on AP. Okay. Now tilt submental करने के लिए ऐसा tilt करो मेरी तरफ. करते जाओ around 20 degrees to 25. ठीक है. So sir, this is pure AP submental. Shoot करना. हाँ दिखाना. अपने तरफ ले लीजिए थोड़ा सा. आप अपनी तरफ ले लीजिए. Okay, good. फैक्टर बढ़ा दीजिए, केवी बढ़ा दीजिए. हाँ हटाता हूं. अब टिल्ट टुवर्ड्स मी, ऐसा इसको ऐसा मेरी तरफ रोटेट करना है. यस, करो. Okay.
How many degrees to
Around sir, around 20 degrees.
Okay.
But you can get from a range of 15 to 25, sir.
Okay.
हाँ अभी शूट करो. Okay.
Now here, I mean, where is exactly?
Yes. I'll show it to you, sir. We'll show you a better picture. This is not very clear picture.
Okay.
हाँ ठीक है, थोड़ा सा और ओब्लिक करिए, मेरी तरफ रोटेट करिए थोड़ा और. हाँ थोड़ा अपनी तरफ लीजिए. हाँ और टिल्ट करो, थोड़ा सा टिल्ट करो, थोड़ा और टिल्ट करो. हाँ अभी दिखाइए. हाँ ये आ गया ना. थोड़ा और टिल्ट करिए. ज्यादा हो गया. हाँ शूट करना. ये ना.
Where, Ashish?
Yeah, sir. This is the oblique. We'll just. हाँ अभी दिखाइए. हाँ. So sir, this oblique view you see is the foramen. और थोड़ा सा कम कर दीजिए. शूट करिए. This.
Can you mark out the boundaries? Because somehow from here we are not able
Sir,
to.
see, I'll show you. This is the mandible.
Right.
This is the mandible. Here is the molar region. Here is the foramen ovale. Not this one. This is the foramen ovale.
Okay.
Here. आप वो केवी कम करिए प्लीज. केवी कम करिए, कम किया, हाँ, शूट दिखाओ, थोड़ा सा बढ़ाइए केवी, नहीं उसमें बेटर था सर, उसमें बेटर, या ओके, शूट नाउ, केवी बढ़ा दीजिए थोड़ा, सर एक मिनट, हाँ ऐसे ही रखना, लास्ट टाइम वी सॉ वाज मच बेटर, हाँ अब शूट करिए, okay sir, now it is beautifully seen, can you see sir?
Yeah, we can make out.
Now this is the foramen oval.
Yeah, very nicely seen.
So sir, once you get this, you just need to shoot please. Yeah, it's very clearly seen sir.
Yeah, yeah.
Very clearly seen.
So now it is just going to be an end-on passage. That's
I'm
it.
sorry sir.
Now it is just going to be an end-on passage.
Yes, just end on. You need to, sir, basically end on, but it is very important that your needle does not pierce the buccal mucosa. That is important.
Yes.
Shoot, please. Shoot करना. Shoot. Lateral would be better. V1. Shoot, please. Shoot. Okay. Now lateral कर दीजिए. Sir, is this? Can you show the position of the C-arm? आप C-arm की position दिखा दीजिए.
Right.
Sir, is it clear, sir?
Absolutely, very clear.
Okay, okay. Now just lateral कर दीजिए. So sir, again another word of caution is just let it go there, but don't pierce the whole thing, because then you can go beyond the clival line, which is not what we want.
So again, Ashish, show us how to reach the V3 and V2.
Yes,
the
sir.
bony
Yes,
land
sir. I'll
perspective.
show.
And how to avoid V1.
Yes, sir. हाँ, अभी इसको सीधा रोटेट कर दीजिए. या बस इसको और सीधा करिए, टेढ़ा है अभी भी. हाँ, अब नीचे ले आइए.
So
हाँ,
there is that
अब
edge
पास लाओ. अब वापस
figure
इसको रख
also,
दो.
which consists of two vertical lines, the medial
Yeah.
word of the mandible and the
हाँ,
lateral
अब
edge of the
शूट करिए.
maxilla,
थोड़ा हाइट बढ़ाइए.
and the horizontal line is the superior line of the petrous ridge.
बस.
So I
चल.
will share this on the
फैक्टर
group
सेट
also.
करके शूट करो. What was sir's question? Okay, yeah.
Yeah, on lateral view,
Yes, sir.
how
yes,
do
sir.
we access the V2, V3 and how to avoid V1?
Yes, sir. So, एक short लो कम KVA के साथ. Okay, so sir, here, just a minute, इसको उठाएंगे. अभी एक short लेना please. Still okay, but not very good. हाँ, अभी short लेना. हाँ, थोड़ा आ गया है, मान लो. ये अभी shoot करो. Okay, this is a good view, I'll say.
So
it can be better.
Yeah, please identify all the landmarks
Yes,
for the
because
benefit
we
of the
have to
audience.
see the clival line. इसको हटाएं अपन देखें. हाँ, अभी shoot करना, एक मिनट देखें. हाइट नीचे करिए. हाइट नीचे करो और केवी कम करो. केवी कम करिए. हाँ, बहुत कम हो गया. Yeah, so sir, now it is seen. So basically, sir, can you see the clivus, sir?
Just show it to us properly. Yeah.
Okay. So yeah. So that is the clival line, sir, which is being shown, and our needle is थोड़ा सा factor और बढ़ाइए, थोड़ा सा factor और बढ़ाइए.
So it's the needle is just touching the clival line, isn't
Yes,
it?
sir. It is. We'll make it more clearer, sir. अब shoot करिए. Yes, sir. Now this is the clival line, and we are just at the clival line. So, sir, basically there are two or three ways. One is that obviously you stimulate and the patient tells you the area where the patient is having pain. That is the best way to tell. But radiologically, you cannot go beyond 5 millimeters of the clival line. Generally, we stick much less and we go just 1 or 2 millimeter beyond clival line at most. So, clival line, you can say that it is V2, and just below the clival line is the V3.
So can you repeat it again? At the clival line, it is V3.
V2, beyond clival line on the towards cranial side would be V1, and towards the heart palate would be V3.
Good.
Is it okay, sir?
Perfect, perfect.
You need to withdraw it. I have withdrawn it. Shoot, please. Shoot, please. ये सर मैं थोड़ा अंदर ले जा रहा हूँ. हाँ, शूट करिए. हाँ. So, sir, what Dureja sir is saying is that if he has to do V2, this is the right place where he'll place the needle. If he has to do V3, he'll come a little more proximal. Shoot kariye.
How many millimeters proximal? 5 millimeters?
Sir, 2 to 3 millimeters, that's all. Sir.
That's all. Okay.
Inside. Okay. For V3. Yes. For V2, we need to go further. Yes. Yes. Any more questions?
Any other questions from the audience?
If you are going V2 and beyond, you will get CSF.
Okay. Thank you, Ashish. That was an excellent demo. We all really enjoyed it.
We'll show that. Okay. नहीं long वाला route दिखाना है क्या? As you wish. As you wish.
Ashish, there's a question from Dr. Hitesh that besides radiological and clinical, are there any surface anatomy landmarks for directing the needle?
Yeah, there are. Like you have the Hartel's lines which go through the external auditory meatus, the zygoma. But what I use basically is I start from the lateral canthal line and go towards the mid-pupillary line.
Okay.
So that and towards the zygoma. So it's a three-way. One is mid-pupillary line towards the zygoma.
Towards the zygoma.
Towards the zygoma means height-wise towards the zygoma, and mediolateral towards the mid-pupillary line.
Okay. Okay. So Ramesh, anything else, or should we divide the groups now?
Yes, sir.
Ramesh?
But then the whole group can see at one time, ना अगर अपन कर देते हैं.
हाँ ठीक है दिखा दो सर.
हाँ, तो
Sir, there is a posterolateral transforaminal Dr.
Okay,
Ashish wants
okay,
to show.
okay.
This will be the last procedure.
Okay.
I think we'll do it quickly, and then the
इसको
candidates who are supposed to come to the camera
lateral कर
lab, please
दीजिए.
get ready, and then
Lateral.
you can be here.
वो long. Can you give me the long needle?
So this is the approach to the Camben's triangle, which Dr. Ashish is going to show.
Yeah. पास लाइए उसको. पास लाइए. पास ले आइए. हाँ. शूट कर दीजिए, हाँ ऊपर
एक्सरे
लेके
को
जाइए,
पीआईपी में डाल दीजिए,
ऊपर लेके चले जाइए, नहीं
एक्सरे
बहुत ऊपर
पीआईपी।
नहीं, थोड़ा ऊपर, बस, ओके, शूट करिए, फैक्टर इंप्रूव करिए, हाइट कम करिए, हाँ शूट, okay. So as I was telling you that
एक्सरे इन पीआईपी।
as I was telling you for say for a L45, the entry point on the lateral side, as you can see here on a
Yes.
lateral X-ray,
Yes.
has to be the apex of the facet joint. Shoot, please. Shoot, please. दिख नहीं रहा है यार वहाँ नीडल मुझे.
So Ashish, you
I
said
don't
for
know, needle दिखनी
L45,
चाहिए यार. थोड़ा
L45
हाइट कम कर दो
it
यार.
should be apex
नीड
of
नहीं,
facet
बढ़ गया है
joint.
उधर, खराब दिख रहा है. कम कर दीजिए.
Lateral view is not good on this X-ray.
Shoot, please. Okay, suppose, so my entry point would be here, needle दिख रही है. Okay.
We are
So-
unable to see it, but it's okay.
You are able to see the needle?
No, no.
हाँ अभी नीडल दिख रही है.
Not to us. थोड़ा उसका वो ब्राइटनेस कम करो.
ब्राइटनेस कम करो, वो लोग कह रहे हैं. शूट करो. शूट.
हाँ, now we can see. Now we can see the needle.
शूट करो, दिख नहीं रहा है मुझे. नहीं, फैक्टर इंप्रूव करिए. शूट. ओके.
हाँ, much better. Much better. ब्राइटनेस कम करो.
देखो भाई वो क्या बोल रहे हैं.
Ashish, there is one question.
Yes, sir.
When you go so laterally, how do you ensure that you are avoiding any organs?
Yes, sir. That is why this line is important, sir. That when you are at L45 or L34, you can go up to the apex of the joint. Whereas when you are at L12, L23 level, you can go only till the tip of the spinous process on lateral view. Because the peritoneal structures are higher up in the at the higher level, whereas they fall down at the lower level.
Understood. So you are saying they are more superficial at the higher level.
Yes, yes, yes.
In terms of the
Yes,
and more
yes.
deeper in the lower level.
Lower
so they are
level.
far away when you
Yes, yes. Shoot, please.
up to the joints, up to the facet joints.
Shoot, please. नहीं, बंद करो.
So in this approach, we use only lateral X-ray initially.
You can use lateral or AP, but I am trying to demonstrate अभी lateral में.
Okay.
शूट करेंगे प्लीज, देख लें कहां पर है. ओके. शूट प्लीज.
So we are thinking at the superior articular facet. Just so body is posterior.
शूट प्लीज.
This is the posterior margin of the body, sir.
शूट प्लीज.
And ये है. This is the forearm. हाँ ऊपर है.
शूट प्लीज.
ये है body, sir.
ओके. AP कर लीजिए.
हाँ, now he's come into the.
Instead of L45 here, I am just trying to demonstrate L34.
Right.
शूट कर लो. AP कर लो.
So I think everybody can appreciate this is the keyhole of the transforamen or the foramen, and he is at the lower border of this L34.
the apex of the joint. Yeah. हाँ, अपनी तरफ कर लीजिए. इधर midline दिखाना है मुझे. Midline दिखा दीजिए. नहीं, AP में. AP रखिए और अपने तरफ खींच लीजिए आप. लेते जाइए और लीजिए. हाँ, बस. चलो, शॉट ले लो. फैक्टर कम कर लेना. Shoot, please. Okay. Shoot, please. Okay. Shoot, please. Okay, so this is medial थोड़ा factor कम करिए. This is medial pedicular line.
Right.
Okay. Inside the foramen, infraneural Camben's triangle safe.
Right.
So you can do a discography here, or you can, after you have removed the trocar, you can put in K-wire and then dilator and go into the disc for an endoscopic procedure.
Okay.
So this is for discogram and for the endoscopic procedure. Shoot karna. Shoot. Shoot. Shoot.
So Ashish, in this.
Okay, this is for the root block.
Right.
The inferior end plate. So this is still the Camben's triangle. Okay, if I'll show you the Camben's triangle, so the root is coming like this. Okay, and then you have the superior articular process here.
Right.
And this is the lower edge. So this is formed, this is the Camben's triangle here.
Okay.
So you are at the middle part of the Camben's triangle.
Where is the pedicle?
The pedicle is, one pedicle is here.
Right.
This is one pedicle.
Right.
The other pedicle is here.
Okay.
Okay.
So in this, we don't need to do the Scotty dog view. We can
No. Just AP lateral.
standard AP and
Standard AP, standard lateral. You can do root block. You can do root block. You can do epidural, because I'll just show you. Shoot. See this, I am almost touching the epidural space. So I can inject epidural here. If I bring it out, I can do a root block. Shoot kariye. Here I can give a root block.
Right.
And suppose if I go down, shoot kariye, I can do a discogram or get into the disc. Okay.
Understood. Very nice demonstration.
Okay.
Sir, can you show us on the
Ashish,
Yes, sir.
just one concern. When you use such a long trajectory,
Yes,
how
sir.
much local anesthesia you have to give? Would the trajectory be painful?
No, sir, it is absolutely not painful. In fact, sir, when we are doing transforaminal discectomy, sir, endoscopic, this is the only route that we use to introduce the endoscope, and it is done under local anesthesia, sir.
Okay.
So there is hardly any pain that the patient feels. Though, sir, myself, I have shifted from local to general anesthesia as far as transforaminal endoscopic discectomy is concerned.
Any other question?
So on the patient, the positioning, insertion point.
Can we just zoom the camera? They want to see the needle entry point on the cadaver. Full screen kar do. Full screen. Okay.
So suppose if I remove this, then I introduce my K-wire. So through this the K-wire goes, then I remove this, and through the K-wire the dilator goes, and then you are inside the, if you are doing a transforaminal endoscopic, either disc or biopsy or evacuation of pus, whatever you want to do. No, for L5S1 I don't use this, because again, as I was mentioning in the lecture, for L5S1, see, L5S1 is this. So here is the iliac crest, the transverse process, and sacral ala. All three prevent me from going. So this
Light
long
कम कर दे.
trajectory is good for L3-4, L4-5, but not for L5S1.
So it is now 12:40. We immediately break for the cadaveric hands-on.
Any other?
No, thank you, Ashish. Thank
Okay,
you.
Okay.
So we break for the cadaveric and the ultrasound stations. So I think everybody knows. Any confusion, we have our staff waiting outside. So I would request, because